to come and start the second session.
Good morning again. So basically I will just go through the slides. This presentation was made by Dr. Immunoncology, and as research he could not be here because of some administrative reasons. So his topic was in the area of immunotherapy. Is immunotherapy or targeted therapy combination with radiotherapy optimal integration? So basically this talk covers these all things: basics of immunotherapy, rationales of combining radiotherapy and immunotherapy. Is there any evidence of which is supporting radio-immunotherapy combination in preclinical setting? Is there any clinical evidence? And is there any safety issue with targeted therapy and radiotherapy, followed by suppression? So our immune system and cancer are always abnormal mutated cells which is prone for unrestricted proliferation. They are always in fighting mode. Like if patient cells are controlled by our own immune system, then that will eliminate the cancer abnormal cells. If there is equilibrium, then some sort of cells with abnormal behavior will stay, may not be totally uncontrolled proliferation, but still there is always risk. And there is third setting in which this cancer cell, they escape the normal immunity, the normal protective mechanism of our physiology, and then that lead to progression of this process and uncontrolled proliferation as we call cancer. So this is a cartoon which is depicting immune elimination of abnormal cells, or for that discussion matter here, those abnormal cells are cancer cells. The tumor cells with any specific antigen, they express some sort of abnormal proteins over their surface. These abnormal proteins are detected by antigen-presenting cells. Then antigen-presenting cells deliver to those cells to our immune cells, and then immune cells do selective killing of those cells, cytotoxic T cell mediated killing, and then cytotoxic T cell infiltrate into the tumor and further enhance the elimination of abnormal proliferation of the cancer cells. And a proportion of T cells then after this process is complete will stay for long as memory T cells, as we know that. So this is a cartoon again depicting this same thing in detail of escape mechanism of abnormal cancer cells from the normal immunity. So this cartoon is showing how cancer cells defy immune system. This process in our normal physiology, there are specific T cells which go on hovering in our body and detect any abnormal expression of any abnormal antigen, which is expressed by an abnormal proliferation by cancer cells. As these abnormal cancer cells, they decay, they also die, then that particular abnormal protein is also released into systemic circulation. And from that systemic circulation also, that abnormal protein is detected by this our normal surveillance system cells, and then that is presented to our immunity, and those cells are escaped. So why we are discussing these things? We are discussing these things because what radiotherapy does, radiotherapy basically increases the breakdown of cancer cells. So that abnormal proteins which are staying inside the cells, or which is staying over the surface of the cells and is controlled by some sort of escape mechanism, is further exposed to our immune system. So that process is enhanced by radiotherapy damage. So this is one of the rationale why radiotherapy enhances immunotherapy activity. So this is the same process. Other than this direct damage of the cell, there is also well-established effect of abscopal effect, that is distant effect of radiation. That's also said to have some contributory effect on radioimmunotherapy positive outcomes. Then there is one other mechanism which has been recently described, which is syngastic pathway, again new pathology pathway, which is also one of the rationale for explanation of radioimmunotherapy benefits. Now next few slides are on mechanism of anti-PD1 and PD-L1 and CTLA4 inhibitors, like immunotherapy mechanism of action. These are various molecules which are expressed by T cells. So T cell killing of cancer cells is a complex process. It involves killing of abnormal cells, but it's also intended to spare the normal physiological cell. So T cell express fewer co-stimulatory molecules, which if detect abnormal cell, then that is going to enhance proliferation of T cells so that abnormal cancer cells are killed. But there are also some inhibitory molecules which are expressed on these particular cells only, so that if those are stimulated, they will detect self versus non-self, and those cells, those abnormal cells, even though they are not normal, but still if they stimulate those inhibitory molecules, then they will escape the normal physiology of immune therapy killing, cytotoxic T cell killing. One important marker in this aspect is interaction of CD28 and B7. And other is CTLA. If it's a normal process, CD28 is coming in combination with B7, its co-stimulatory pathway is activated and cancer cells are killed. But if the same interaction happens with CTLA4, then that interaction of cytotoxic T cell mediated killing is inhibited. So if we target that by any drug like ipilimumab, if CTLA4 interaction with B7 is inhibited, then that normal physiology of detecting abnormal proliferation of cells and abnormal antigen will be enhanced. So the basic gross depiction is radiation kills the cancer cells, antigens are exposed, which are detected by immune cells, and along with that, if we inhibit that abnormal inhibitions of detection of killing of this abnormal cells by immunotherapy like ipilimumab, so if we combine these both effects, then there is maximum benefit. That benefit can be at local site, and that benefit can also be at distant site. This is one of such initial few case reports which showed if we irradiate baseline the primary pathology and give chemotherapy along with it, there is a significant response. Even near CR has been reported by combining radiotherapy followed by immunotherapy, or radiotherapy combined with chemotherapy all along. One of initial few research done by this person from University of Pennsylvania. So he combined SBRT. This was the schedule of combining SBRT with ipilimumab. This was one of the initial few trials which showed promising results. There was no neurotoxicity or abnormal behavior which happened because of combination of radioimmunotherapy. So this was basically a feasible combination. Only is anemia a bit higher in combination of radioimmunotherapy, but that was also not statistically significant. So this is showing waterfall curve is showing that local effect was there, but there was also some distant effect of radiation. That means local lesion was healed, which was subjected to SBRT, but also the distant lesions, they were also showing positive response, and even some few CRs were reported in few anecdotal studies. Then next few slides, I try to depict preclinical or basic evidence before starting this radioimmunotherapy era. So this was the mouse model which was studied in melanoma. Melanoma, as we know, is one of the most high tumor mutation burden lesion. So it's prone to have neoantigens, more and more abnormal molecules which is expressed in melanoma cells. So melanoma is basically one of the ideal disease to study the radioimmunotherapy. So it was done practically also. So initial studies were in melanoma only, and from melanoma we have tried to extrapolate those studies into other solid tumors also. So what all these slides are showing, this is a slide in human, that this is showing if we combine radioimmunotherapy, then our friend T cells, which are going to detect abnormally expressed antigens and kill the cancer cells, that expression is increased after we combine radioimmunotherapy. Important point here is that expression is much more high in PD-L1 positive cells, and that is proven in melanoma series. So this slide is depicting that only. If patient is having PD-L1 positive, sorry, I gave exactly opposite narrative. So if patient is having PD-L1 positive, then this newer reactivation of T cell is minimum. But those tumors, those who are having PD-L1 negative cells, there is maximum chance of new T cells are reactivated, and that's going to kill that's going to enhance the normal physiological killing of abnormal cancer cells. So this was the initial study was in melanoma. So to summarize, radiotherapy and anti-CTLA4 and PD-L1 inhibition that increases the effect of both immunotherapy as well as radiotherapy, and the effect is increased both locally as well as at a distant site. Now these few slides are depicting tumor infiltrating lymphocytes, the local inflammation milieu of the tumor and the impact of radiotherapy. If the TIL is high, then our immunity is as such strong, so not much benefit of combining radioimmunotherapy is going to be there. But those with low TIL and low expression of PD-L1, that is having maximum promising result with combining radioimmunotherapy. These are the ongoing data which is which has recently published in early stage phase, like preclinical and clinical phase 1 and phase 2 trials, but major phase 3 trial is still to be published. But there are studies in colorectal cancer and other primary, especially in melanoma, that has shown a promising result. In breast cancer, the maximum results are anecdotal reports and series, and that too in triple negative breast cancer. In those patients, there is maximum benefit of combining radioimmunotherapy. Now, next few slides are on targeted therapy and safety of immunotherapy. So this one slide, few slides are on trastuzumab and radiotherapy safety. So these all trials, they studies whether there is an interaction of radiotherapy and trastuzumab. Because initially there were few trials, even post-marketing surveillance that shows that trastuzumab can have, later on trastuzumab can have adverse outcomes in local suture sites, but that has been disproved by so many trials. Then there are studies which have shown that combining PARP inhibitors and even fewer latest evidence of combining CDK4 inhibitors, that is safe and that is feasible, and there are no newer safety markers associated with it. So radiotherapy and chemotherapy, immunotherapy together seems to be a thing for near future. Radiotherapy alone is tool for local treatment. Addition of immunotherapy will convert radiotherapy from a local treatment to a systemic therapy like chemotherapy. And plenty of preclinical and some clinical evidence suggests that distance response of combining this modality increases the outcomes even at a distant metastatic site. Once proven or metastatic setting, it can be tried in early breast cancer. So as we know, breast cancer is different from other solid tumors. As we say, breast cancer is a systemic disease even to start with. So if we combine radiotherapy and immunotherapy in some trial and we try to study the combination outcomes, as it's a systemic disease, so we may have some positive outcomes that need to be studied. Thank you. So this presentation was from Dr. Venkateshwar, so I won't be able to answer. I just read it.
I think that was a fair point, Dr. Amit. We won't be asking you any questions regarding that. But a very, very interesting presentation. I'm sure the radiation oncologists really listened with intent to that one. There were so many concepts. And there were so many interesting concepts, the concepts of radiosensitization, the concept of the ideal sequencing of immunotherapy and radiation. I really would like a comment from the chairpersons and panelists on this issue as to what they do in their clinical practice and if there are any personal anecdotes to share.
Maybe I would like to add, or if someone can answer, like when we combine routine chemotherapy with radiation, apart from the positive effect, we have more side effects, we have more toxicities. So in the same scenario, if we combine immunotherapy with the radiation, so apart from getting the positive effect, there may be more toxicities.
Absolutely.
So Dr. Amit or anyone else, you can elaborate on that?
I think that's a very, very interesting question. So if anyone in the audience would like to.
So I think like if you have to combine your immunotherapy with SBRT, there isn't a problem. We give, because SBRT is generally 1 fraction, 3 fractions, and then you go ahead and start your immunotherapy. But yes, if you are treating something like breast cancer and it is a metastatic site, you are treating it for increase in the breast lesion, and you are treating the breast lesion, then normally you would say like Palbo, the other day we were seeing, so it has got pneumonitis. So radiation and then Palbo, it may induce increased pneumonitis. So in these cases, like it is.
In fact, in a couple of patients in our hospital, we recently had some metastatic patients in which we did stereotactic radiation, and then they were immediately followed up by immunotherapy, and we had no problems of toxicity. And this is a new concept, and I think this is going to catch up as we are progressing more into phase 2 and then phase 3 trials.
So this is a new concept, not much explored, but yeah, whatever data we have more of data in melanomas where Dr. Amit presented, and there were some adverse effects more related to anemia, not grade 3 or grade 4, which can be easily managed. So I think this is a new concept, and it can be used safely if we need more phase 3 data for in breast cancers. But yeah, it is quite promising.
So I think we have to be very careful when we are combining them. Apart from looking at the positive effects, we have to be very careful for looking at the adverse effects.
Absolutely.
Sir, actually, one of my slides was dedicated to that question only. There was no alarming new symptoms. There was no new toxicity with combination of SBRT with immunotherapy. But other than SBRT and immunotherapy combination, that thing need to be studied. But there is ample evidence that if you combine SBRT and immunotherapy, there is no new safety red flag sign.
Yeah, precisely because in SBRT, the treated volume by radiation is very less. And as we gather more experience with SBRT, then we can graduate on to the larger field radiation as well.
One message that I would like to give here is that because SBRT and immunotherapy, they lead to abscopal effect, and you give SBRT to one site and benefit can be seen at other sites as well. So response evaluation, whenever you do it, should not be done only of the site where you give SBRT, but I think PET scan should be done for the whole body. And one thing which is more important is that with immunotherapy, you see a lot of immune-related adverse events, say hypophysitis and other side effects as well. So even if you are doing an imaging for a not expecting any lesion in the brain, then brain should also be evaluated, and limbs like for melanoma specifically. So if it's not just the response that we are interested in, but I think a lot of close watch is to be kept for immune-related adverse events, which are absolutely totally different from the common cytotoxic side effects of chemotherapy.
And moreover, we have to be more conscious in selecting or labeling those patients who have some immune-related disorders, because they are those patients who may give you a very shocking scenarios in clinical practice. So otherwise also we look for patients who have some immune disorders, but if we are combining these two, then we have to be
Fair point.
And I think apart from the toxicity aspect, what Dr. Amit told in one of his slides was, otherwise what we see is, higher PD-L1 expression leads to good responses, but contrary in patients in which we are combining immunotherapy with radiation, the lower the PD-L1, the better was the response. Is it?
That was the basic rationale of inhibiting PD-L1 with radiotherapy. Because if PD-L1 is already absent, so there is no fun of targeting that.
Dr. Bharat, can I just add a comment, not specifically to immunotherapy, but what I would say is that when it comes to cancer care, these are very exciting times. We have a barrage of targeted agents and immunotherapy, and the number of approvals which were being shown. The thing is that to make sense of all this complexity is not going to be an overnight job. A lot of work has to go into, and we have this concept of combinatorial therapy in immuno-oncology field particularly, but I think it's not only immuno-oncology, a lot of targeted agents, immunotherapy and all. So what seems to be a future, I am not saying it's a near future, is that lot more of metastatic cancers will come into the domain of long-term survival and potential cure by a combination of new agents. So I believe that the old concept, then when it is metastatic disease, leave it to the medical oncologist. So probably we need to think about integrating local therapies in metastatic cancers as we are able to take care of the distant disease. So from that point of view, all of us need to really cooperate much more in every single patient, however advanced the disease is. So make that our guiding principle. That would be my thought.
I have one question.
Yes, ma'am.
So now this is a combined therapy which we are giving, like RT and immunotherapy. So from a pathologist point of view, I would like to know, is there any protocol set that as and when the laboratory investigations are going to be done, what is the routine, how it is going to affect the hematological parameters? Because we in Venkateshwar laboratory medicine, we often get calls from the radiation therapists as to they are so much concerned about the platelets and so many other parameters. So will all this increase, or it will be as the monitoring will be the same?
Would anyone like to take that question? Actually, ma'am, we have a pathology session coming up after 2, but if anyone would like to take that question.
I think with the immunotherapy, there are a lot of immune-related adverse events like hepatitis may happen and hypophysitis, pneumonitis and all those things. So there can be some transient elevation in your liver function enzymes if the patient is on immunotherapy. It may not be proportional to, because with immunotherapy don't expect these to happen, but there can be definitely hepatitis and hypophysitis may happen, so there could be some change in your hormone profile of the patient as well. So, and as you asked about platelets, then it could depend if you are combining radiation with immunotherapy, and if your radiation field is quite large, depending on the area that you treat, then you can have drop in platelet counts. And it also would also be a reflection of the chemotherapy protocol that the patient has previously received. So patient may have delayed side effects of chemotherapy as well. So I think when the lab reports come, it's very pertinent for all of us to give you the clinical history and what all treatment the patient has received. That may help in understanding the side effects much more.
In continuation of that, like immunotherapy drugs, they are pretty safe drugs, but if they are having adverse effect, that adverse effect can be life-threatening. So it's not the issue of combining radiotherapy and increasing toxicity. You have to be vigilant even if you are giving the single immunotherapy drugs. Still you need to be very vigilant and test and clinically evaluate as well as lab and biochemistry for every patient. So patient can manifest starting from hypophysitis to thyroiditis to colitis to pneumonitis. Any itis can happen in the body. So you need to be a good clinician. A best internist is the best person to treat with immunotherapy. So is the case with combining radiotherapy and immunotherapy.
Any other comments from the chairperson or the panelists? Any other questions from the audience for the chairpersons, the panelists? Oh, we have one.
As a radiation oncologist, I'm really perplexed. What purpose you are giving immunotherapy? Are you giving it as a radiosensitizer or a primary treatment? Because normally for a metastatic disease, we use 5 to 10 fractions. If you start day 1, day 3. So are you using it as a radiosensitizer or as a primary therapy? Because it's totally different, isn't it? So can somebody answer that? What is the advantage of adding immunotherapy from day 1 for 5 days of treatment of radiation, up to probably 10 days? Will it really make a difference? Or if you start later on, are the two different?
I think that's a very interesting question, and I think it's open to anyone if they would like to take it.
Normally when we give metastatic disease, you keep radiation metastatic, you are not doing radiosensitization. So what are we trying to do here?
I think what I understood that the immunotherapy is being started as a systemic therapy, and radiation till now is being used in a very focal, very restricted way, mostly stereotactic, so that both therapies can start simultaneously in these patients. But as we gather more experience, then we will maybe expand into other things.
anyone else care to give an answer to that question? Any other questions from the audience? Any of the surgeons would like to say anything on this? What they feel regarding the integration of immunotherapy and radiation, and do they feel they need to come in the picture early or maybe later, or they need to be a part of the discussion? As sir mentioned, all therapies need to sort of integrate and discuss with the patient who's on immunotherapy. Would any of the surgeons like to say anything on this? Dr. Geeta, if she's still there. Ma'am, would you like to say anything on the integration of immunotherapy and radiation, and how and why the surgeon would come into the picture? Would
Very, very premature. Honestly, I would not want to be
even you would not. You would not.
saying anything at all.
All right.
Basically, the concept of combining the two in any metastatic setting, like if any metastatic disease, oligometastatic disease is there, and we are doing SBRT to a small area, perhaps abscopal effect will decrease the lesions in the other area. So perhaps this is the concept where you are combining radiation with immunotherapy. So that is taking care for metastatic disease when we are irradiating small area by stimulating the immune response by giving SBRT to small areas.
So I think this session has generated some interesting questions regarding as to what exactly is the benefit of combining immuno and radiation oncology, and what should be the sequencing, what is the intent, how you evaluate the response. Many questions have been generated, and I think we'll get the answers in the subsequent sessions. So if there are no further comments, I'd like to close this session, and I'd like to ask for Dr. Rakhi to please come and present the mementos to our chairpersons, panelists, and our speakers. Dr. Rakhi is Senior Consultant and Director Radiology at Venkateshwar Cancer Center. Can we have a round of applause, please? Welcome, ma'am, please. Can someone please bring the mementos? If I just ask the chairpersons to come and receive their mementos, please. Can I ask Dr. Lavneesh Goyal, Director, Medical Oncology at our hospital, to please come and receive his memento? Can we have a round of applause for our chairpersons, please? Dr. Arun Goyal, Director, Surgical Oncology, Max Vishali. Sir, could you please come and receive your memento? Dr. Anurag Jain, Head of the Department of Radiology, Action Cancer Center. Can you please come and receive your memento, sir? Dr. Dinesh Singh, sir, Director, Radiation Oncology, Max Group. Can you please come and receive your memento, sir? I'd also request our panelists, Dr. P.K. Sachdeva, sir, can you please come and receive your memento? Can we have a round of applause, please? Dr. Rajendra, Head of the Department of Radiation, Fort Shalimabad. He could not be here with us today. Dr. Kuldeep Sharma, sir, Senior Consultant Radiation Oncology, Venkateshwar Cancer Center. Can you please come and receive your memento, sir? Dr. Dinesh Katyar, sir, could you please come and receive your memento, sir? Dr. Mohit Sharma, sir, could you please come and receive your memento? And lastly, I'd like to call upon Dr. Amit just once more to receive his memento. Can you please have a round of applause for him? He's taken 2 presentations, that's not easy. A round of applause please for Dr. Amit. He's taken 2 presentations and 1 outside his field. Thank you, everyone. So now we'd like to start the 3rd session. The 3rd session is titled, What are the challenges in radiological response assessment in immunotherapy and targeted therapy? And this session might answer some of the previous questions in the previous session. I'd like to call upon our speaker, Dr. Anurag Jain, Head of the Department of Radiology, Action Cancer Center, to start the 1st session. I'd like to also call upon the chairpersons for the 3rd session, Dr. S.K. Verma, Director, Medical Oncology, Himalayan Institute, Dehradun, Dr. A.K. Devan, Director Surgical Oncology, RGCI. Dr. Arun Agarwal, Director Radiation Oncology, Aadhar Hospital, SAR. Dr. Anupam Mandal, Head of the Department Nuclear Medicine, Venkateshwar Cancer Center. Dr. Rakhi Gogoi, Senior Consultant Director Radiology, Venkateshwar Cancer Center. Can I also call upon our panelists? Can I call upon Dr. Indu Bansal, Director Radiation Oncology, Narayana Hospital? Can I call upon Dr. Rashi, Senior Consultant Radiation Oncology, Max Vishali? Can I also call upon Dr. Praveen Bansal, Director Medical Oncology, Asian Hospital? And lastly, can I call upon Dr. Vedant Kabra, Director Surgical Oncology, Manipal Hospital? Can everyone please come to the dais? Very warm welcome to the chairpersons and the panelists. I'd like to call upon Dr. Anurag Jain sir now to start the third session.
Hi, morning. I am Dr. Anurag Jain. I am a radiologist, and I will be talking on the challenges in response evaluation in immunotherapy and targeted therapy. As you know, the conventional therapy, the cytotoxic therapy, has been the mainstay for long, and the morphological assessment has been the mainstay for assessing the response. And RECIST 1.1 is the newest and most widely accepted method to assess the response. And it uses unidimensional diameters of the target lesions to measure the response. Now the RECIST 1 has changed, it started as RECIST and now the RECIST 1. So many things have changed. It has better defined target lesions, what can be taken as a target lesion, the size. It has to be on a CT more than 10 millimeter, on an X-ray more than 20 millimeters. The size of the measurable lesion. The lymph nodes are better characterized. Now the lymph nodes can be taken as target lesions with more than 15 millimeters in short axis. Then less than 10 millimeter would be non-pathological, and an intermediate size can be a non-target lesion. The PD of target and non-target lesions is defined in greater detail. PD, as in the previous version, is more than 20% increase in the sum of the measurements, but it has to be a minimum of 5 millimeter increment increase. So taking away the the reproducibility issues and the small increment which can have a greater percentage in terms and cannot be labeled PD. Non-target lesions, things have changed now. It has to be an unequivocal increase as per the RECIST 1, not just if the non-target lesion increases. Specification of new lesions is given. Appearance of a new lesion is not sufficient. I mean, it has to be truly characteristic of a new deposit of the disease in question. Cystic lesions are better defined. Cystic lesions are now included. A simple cyst obviously is not included, but if a cyst is known to be a malignant of malignant nature, and there are cysts which are of definitive malignant appearance, they can be included. Bony lesions are now better defined. The soft tissue component associated with bony lesions can now be measured, and it can be followed as well. An appendix has been given for the use of MR and FDG PET. Now FDG PET is included, and it also specifies the situations, like if there was no FDG PET at the baseline, and now if there is an FDG PET now, and for MR, the detailed explanation is given how it should be done. It has to be a contrast, it has to be a contrast study, and then how do you use it? So all those details are now there in the RECIST 1.1. Now there are certain limitations to the RECIST which are in general, not just immunotherapy, targeted therapy. In general there are limitations. Variability of tumor size measurements. What is 2 centimeters for me, for my colleague, it may be 2.5 centimeters. There can be variability of tumor measurements. Tumor heterogeneity is another issue. Small volume disease obviously can have a greater percentage of measuring variability. And then the non-measurable disease, leptomeningeal disease, ascites, pleural, pericardial effusion, inflammatory breast disease, lymphangitic involvement of skin. So these are non-measurable disease. But in RECIST 1.1, they have given a breather. If there is an unequivocal increase in non-measurable disease, like if we see just a stranding of the omentum and now we see a big cake, we can put the button. This is unequivocal increase and would be taken to be as PD, because the issue is in many cases there is only a non-measurable disease. So there was a need to better define this. Now coming to the limitations specific to precision therapy, and the understanding of the dynamic interplay between the tumor and the immune system is becoming, we are becoming wiser, and it is revolutionizing the cancer treatment. And over the last decade, there have been many newer agents, immunomodulators, vaccines, checkpoint inhibitors, monoclonal antibodies, targeted therapy, which are now being increasingly used. So the RECIST criteria, there are situations in which it does not prove to be very accurate. There are many targeting agents which have anti-angiogenic activity, and they can have a response even without shrinking the tumor. So this is cytostatic effect, classically, like imatinib for GIST or sorafenib for HCC. So we need to know more, and we need to know, we need to have different strategies to address response in such cases. So in GIST, the tumor density is one thing which can reflect response. So Coe et al. Have described the criteria which is useful, and according to which if there is a 10% reduction in the tumor size or a 15% reduction in the tumor density, so that would be constituted as a response. Now I mentioned HCC, like sorafenib is used. So many times it doesn't really cause much of decrease in the size, but the response is manifested by decrease in the vascularity of the tumor. So we have a modification, which is the modified RECIST criteria, which is helpful. So these salient features include that only the arterially enhancing, well-delineated lesions which are reproducible, can be measured later on, are taken to be the target lesions. And then CR is obviously taken to be complete disappearance of all arterial enhancement. The lesion may still be there. You can see the lesion, but there is no arterial enhancement. We would take this to the CR. Progressive disease, if there is increase in 20% in the sum of the enhancing target lesions. And tumor necrosis, disappearance of arterial enhancement is considered a response. Now, molecular targeting therapy in tumors with specific genomic abnormalities can have a marked initial response and then a slow rise in the tumor volume. So this does not reflect a PD. So this is the issue which RECIST cannot address very well. And then RECIST progression does not really mean a treatment failure in such cases. Tumor growth rate, temporally assessed, will come to that, contributes more effectively to taking therapeutic decisions. Immunotherapy, it has been talked in detail. It enhances the immune response of the tumor cells, normalization strategy to break the block of immune response, to reset the natural anti-tumor immune capacity, and because of this, atypical responses are seen, which are unique to immunotherapy. There can be a response after an initial increase in the tumor burden. So this does not mean a progressive disease up front. So we need to address this, which will not be addressed by RECIST. And then a response during or after appearance of a new lesion, like a new lesion, straight away PD. But when the patient is undergoing immunotherapy, we need to be careful. But having said all this, the percentage of patients who will have these unique atypical responses is still less than just about 7-8% in large series. Immunotherapy, let me tell upfront, it is for clinical trials. As a radiologist, I do not report iRECIST. I am not part of a clinical trial which is reporting iRECIST. But understanding of the concepts of iRECIST and its relation to RECIST-1 are important in our day-to-day personalized approach in patients. As we, in the previous sessions talked, ultimately it's going to be an era where we're going to personalize everything for a patient in particular. So these patterns are incorrectly interpreted as a PD, and these are actually pseudo-progressions. There are other patterns which are atypical in immunotherapy, like we can have a disease flare. Disease flare is when you stop immunotherapy for whatever the reason, the disease just flares up. So you don't know when to stop the immunotherapy, except in the setting of a PD. Then you can have a dissociated response. All the target lesions, they disappear, but the non-target lesions, they increase in size, or the non-measurable disease increases in size. So these are big challenges. Like this is a case in which we have a baseline tumor in the right lung, which is marked with an arrow, and in the second image it is shown to be increasing in size on immunotherapy. So by RECIST 1.1 this would be a straightforward PD, but not so if you use the iRECIST criteria. And as seen in the next image, the tumor has shown good response. Another case in which we see the right paratracheal node, which has enormously increased with the new appearance of few prevascular nodes, but however in the subsequent checkpoint 2 evaluation, they've all gone. The other unique response which we get in immunotherapy is hyperprogression. Hyperprogression, in different series I read through, have different incidence rate. It really ranges. It's so variable from 5 to maybe 15-20%. But overall, if we see, it will be on average would be still less than probably 6-7%. Like in this case, you see there is a large tumor in the right lung, and in the first checkpoint, it has almost doubled in size. A definition has been given: if the tumor doubles in size, then it is taken to be hyperprogression. So there are limitations. I've explained all this. The immunotherapy evaluation has evolved over time, is still evolving. The first one was RC, immune-related response criteria, then the RECIST, which was very quickly revised to iRECIST. The differences are, mainly the IRRC was a very tedious way of evaluating. It was copied from the WHO, the last decade WHO criteria. It's bidimensional, and then you sum the 2 dimensions, and then you need a follow-up scan to document PD. So, and there were many clinical trials which were going on, and they were using RECIST criteria. So, to streamline things, the IR-RECIST came into picture, which is more in line with the RECIST 1.1. So 5 lesions selected, the same criteria as in the RECIST, unidimensional measurements, and but the different thing was the new lesions in both IRRC and IR-RECIST were added to the tumor burden. So it was difficult to evaluate again. So the newer version, which is now the newest one, the iRECIST, it changed a few things. The new lesions were measured separately, and the results were documented. A new lesion was, a new terminology was given, which is IUPD, which is unconfirmed progressive disease. It resets the bar. So we will quickly see this. So as per iRECIST, just go to the third column, the PD. This is what is different. So increase in size more than 20% of the tumor burden, or confirmation of the confirmation requires minimum 4 weeks after starting immunotherapy. And if there is a new lesion or increase in more than 20%, it is labeled as IUPD. It resets the bar. Then you need a confirmation between 4 and 8 weeks later on. And if there is a further increase in the target or non-target lesions, an unequivocal increase, or there is a further new lesion, then we would label this as to be a confirmed PD. Now this is, there are three, 4 scenarios I have taken from Lancet, which highlight the differences between conventional cytotoxic therapy and immunotherapy. Like if you see in this scenario, that there are 3 time points, TP1, TP2, TP3. The target lesion increased from a sum of 100 to 128, straight away PD by RECIST, but not so with iRECIST. It's an unconfirmed PD followed up. On follow-up, the target lesion remained 125, so this is still IUPD. But what changed in this TP3 is that the non-target lesion, it showed an unequivocal increase in size. So now it is labeled as confirmed PD. Scenario 2. From 100, the first time point, it increases to 125, straight away PD by RECIST, but not so with iRECIST. It is IUPD. And then the tumor size actually decreased. So it is IPR. It remains so in the next one. So again it remains IPR. And in the next checkpoint, there are new lesions. But it doesn't become PD. It becomes again, the bar is reset. So this again becomes unconfirmed progressive disease. And in the next checkpoint, a further new lesion, yes, we are happy to say it is confirmed PD. Third scenario, straight away, 100 to 125 by RECIST PD, but not so with iRECIST. And in the second one, we see that there is an increment of 5 millimeter increase in size of the target. So now we can safely label this to be confirmed PD. Scenario 4. Excuse me. The lesion actually showed a partial response, became half from 100 to 50. So by the RECIST criteria, this becomes a partial response. And in the second time point, the tumor size remained the same. So again, partial response by RECIST criteria, both by iRECIST and RECIST. And in the third time point, there is a new lesion. It becomes obviously straight away PD with RECIST, but not so with iRECIST. It becomes unconfirmed PD. And in the next time point, the new lesion disappeared. So this becomes a partial response. And then because the bar is reset, it is comparing with the unconfirmed PD scan. And then in the next one, it remains PD with RECIST, but the overall good response, the overall best response with iRECIST here is a partial response. And the overall best response with, if you use the RECIST criteria, it is from upfront, it was PD. For assessing immunotherapy response, longitudinal analysis of the serial changes in tumor burden over time more accurately reflects the tumor behavior. PD-1 inhibitors, it has been seen in many studies that if there's a 20%, less than 20% increase in the tumor burden throughout therapy, then it will have a favorable response. Then the hyperprogression is still something which we need to know more about, whether it is just in a hyper immune response or the immunotherapy has actually affected the tumor kinetics to the extent that it has become completely uncontrolled and uninhibited. So obviously the treatment has to stop promptly. The patient has to be off immunotherapy, and appropriately it has to be done. Then disease flare, yes, I talked about it. When if the immunotherapy is stopped, there can be a rise. So the question is, do we have the option of stopping immunotherapy? It's an expensive therapy on a monthly basis. So except in the setting of PD, stopping it can actually have a flare response. We talked about adverse events. We were discussing, the pathologist raised the question. So as a radiologist, we need to know the adverse events because we image them and they are unrelated to the disease. And if we are not aware of it, then things can be combined and cause confusion. So it is important to know these. The commonest is obviously pneumonitis, and then different other forms of lung toxicity in terms of cryptogenic organizing pneumonia, NSIP, hypersensitive pneumonitis, or even ARDS kind of picture, acute interstitial pneumonia. Occasionally we can have small tiny nodules and a sarcoid-like picture. Few images. One of the very few lectures where I have more of written slides than images. These are two different patients. The first one shows confluent consolidation. There is immunotherapy-related consolidation pneumonitis. In the second one, there is interstitial fibrosis and some ground glass hazing, crazy craving type. The first slide shows chronic lung fibrosis with, as evidenced by traction bronchiectasis. The next slide actually, has the lung window and the PET image. So this is a sarcoid reaction. There are new small lymph nodes with good avidity, tiny nodules, and some fibrosis in the lung. There are other systems, almost all systems which can have adverse events: pericarditis, thyroiditis, hepatitis, all itis, myositis, colitis, pancreatitis, cholangiopathy, endocrinopathy. Just to touch the interesting ones, thyroid can diffusely enlarge, can have a diffuse ectogenous uptake. This is thyroiditis. The second image of the abdomen, diffuse thickening, neural thickening of the colon. This is colitis. Classical pancreatitis in the third image. And then cholangiopathy. Cholangiopathy is like, the patient may have altered LFT. Otherwise, patient will not be very symptomatic, but the LFTs will show it. And surprisingly, for the radiologist, it's significant diffuse neural thickening of the CVD, as seen in this case shown by the arrow. This is immunotherapy-related cholangiopathy. And then hypophysitis, we talked about it in the last session. Diffuse enlargement of the pituitary gland can lead to a varied spectrum of endocrinological abnormalities. New alternate imaging strategies have been tried. The first two, the dynamic MR and the perfusion, they exploit the concept that when a tumor is responding, it gets less of blood supply. So the first two are exploiting that, and they can actually give an idea of the response even before the tumor shrinks. The third and fourth, the diffusion and the MR spectroscopy, they assess the inside environment, the composition of the tumor. So if there are more proliferating active mitotic cells, it will restrict heavily on diffusion. So before the diffusion restriction, when the diffusion restriction goes, it can be really early, much early before a tumor shrinkage happens. The same goes with the choline peak in MR spectroscopy. So the future molecular imaging has to be used for response and adverse events. And novel, we have, I think, a nuclear physicist person in the panel. So we have, various novel radiotracers are being evaluated involving amino acids, nucleotides, choline, S receptors to detect cell proliferation and depth. Various, antibodies, monoclonal antibodies have been combined. It has been tried. Indium 111, Ganzyme PET, and then zirconium 89 and copper 64. These are being used. A very new and upcoming arm is radiomics. Radiologists are not directly involved in that, not even the nuclear physicist guys. See, we assess an image, but we do not assess the image texture. So radiomics is quantification of the phenotype, something in simple terms. So it involves loads of criteria: the tumor volume, what part of the tumor volume, what density it is having, the kinetics. The texture of the tumor is being evaluated by a team of technocrats, software. So it might be the future in predicting response of immunotherapy. Thank you.
Thank you, sir. That was a wonderfully insightful talk and hopefully answered some of the questions posed in the previous sessions. Any comments from the audience, any questions for the speaker, the chairperson, or the panelists are welcome.
If we are using a immunological response assessment, iRECIST, in your center they are using, what are you using?
The principles of RECIST are used in our reporting, and same way we know it's important to understand the principles, how immunotherapy can have a different response and not be a PD even if the tumor burden increases transiently or later on during the course of treatment. So then these things are decided on an individual basis. So in nutshell, if I say yes, iRECIST, clinical trial is coming up, but still the backbone, most universally accepted, most universally understandable, still remains RECIST 1.1. Number one. Number two, the unique atypical responses, pseudoprogression, disease flare, hyperprogression, these have a very small percentage. So taking this small percentage, you cannot take away, change everything. And iRECIST is not now, at least in today's date, not known to everybody to that extent that it becomes a freely communicable and understandable terminology. The first two speaker, he said there are 400 trials going on, but most of the trials are still using RECIST 1.1. But it is important to understand that if a patient on immunotherapy, gets a transient rise, yes, I will write yes. Okay. It is increasing, possibly PD. The medical oncologist and I know, and we, the tumor board knows that this could be a transient phenomenon. We are not stopping therapy. Let's see later on.
That means oncologist can discuss with radiologist.
Yes. And this is the basic rationale that things have to be individualized now till we have a really standardized and widely accepted iRECIST.
Yes, that's a very interesting question. I was hoping someone would ask that.
Sir, like the pseudoprogression is the time point which will decide. Because in the iRECIST, what has changed, that if a tumor increases, doubles in size, no questions asked, it is clear-cut PD. But not so if the patient has been on immunotherapy. So the criteria described here now are that the next checkpoint has to be minimum of 4 weeks later, less than 8 weeks later, and in this window period, another assessment is done, the bar is reset, because it has increased from 100 to 150, we would label this as unconfirmed progressive disease. The bar is reset, it is not labeled as progressive disease, we would wait for the checkpoint 3. In the checkpoint 3, if it remains 150, it remains IUPD, that is unconfirmed progressive disease. If it becomes 155, then as per the criteria, 5 millimeter increment rise, it becomes confirmed PD. So this becomes from IUPD to ICPD. So what was upfront progressive disease with the RECIST 1.1 has taken 4 weeks or maybe 8 weeks to be labeled as a confirmed PD. This is the difference. And this same scenario can occur later on in the treatment course of the patient. Not necessarily upfront that the tumor burden may increase and then decrease. Tumor burden may decrease, but suddenly there may be new lesions, still not progressive disease. Unconfirmed progressive disease. We are resetting the bar. And in the next one, if the new lesions disappear, it becomes partial response.
Sometimes it becomes very difficult. So just let us put a clinical scenario of a patient with multiple lesions, like 4 or 5 treated with SBRT or SRS, and after 3 months, patient having radiological size of the lesion increases. In some, you get decrease in edema. In one of the lesion, edema is increasing, and faintly every one tidbit there, patient is asymptomatic. So sometimes so many lesions treated once or twice, and in third go, it becomes very difficult whether it is progression, static, regression, patient is
very happy to take a question from Jyotika. She is my batchmate. I met her after a long time. Now, Jyotika, there are a few things which the RESIST 1.1 has clarified. Regarding the use of MR, it is advocated that if a disease like lung cancer, breast cancer, which have a high incidence of brain lesions, they should have an MR upfront. For the simple reason that after suppose 6 months, you get an MR, patient has some headache, and you get an MR, and the MR shows one lesion. It will be labeled as progressive disease, even though you don't have a previous MR. So better to have one upfront. Number two, there is a two-compartment model. Two-compartment model means because there is a blood-brain barrier, so you guys know better. There are a few drugs which cross the blood-brain barrier, few don't. So the radiologist is when he communicates with the medical oncology and radiation friends, it's a two-compartment model. We never say overall this is disease progression or overall it is like that. If the CNS disease has increased but our systemic disease is responding, so we would say that in a two-compartment model. Good response outside the CNS and bad in the CNS, so you take it otherwise. Now the other question is doubtful lesions. Doubtful things everybody has. The pathologist also has, the radiologist also has, you also have. The guidelines are if there is an equivocal lesion, it cannot be measured. We will not take it. We will not take it. Number two, what has changed with RESIST 1, a non-target lesion, what used to happen with RESIST, the 1.01, if a non-target lesion, it doubles, suppose it was 5 millimeter, it became 10 millimeter, no problem, this is progressive disease, but not so with RESIST 1.1. The non-target lesion has to have a substantial or, in clear terms, unequivocal increase in the total tumor burden. Then only we will say that yes, this is progressive disease. So this is a matter of communication coming to a conclusion on an individualized basis.
I want to add a point here. I think we are talking about pseudo-progression. So as pseudo-progression is mainly seen in 10% patients, mainly with immune checkpoint inhibitors, as compared to if you talk about PD-1 or PD-L1, then its incidence is around 3%. I think one more important point, which is more important, is that we also have to see whether there is any clinical deterioration in the symptoms of the patient.
Yes, that's an
if suppose the patient is clinically better and has no symptoms, but radiologically is showing evidence of progression, then we may still keep silent, because clinical deterioration is also a must. So ideally, the first evaluation after this should be done maybe around 6 to 12 weeks after you have given the first dose, and then 6 to 4 weeks at least another evaluation has to be done, and then 6 to 8 weeks later. So serial measurements, clinical deterioration, and there are different criteria. Like I was reading somewhere, and there's something which is known as PERMIST, which defines about progression on PET scan, and which says if there is increase in size of 4 lesions increase, but they are less than 1 centimeter, or 3 lesions which are more than 1 centimeter, or 2 lesions which are more than 1.5 centimeter. So I think we have different response criteria for PET, for MR, and as he rightly said that immune resist is not, we cannot yet standardize it. We are into evaluation of, in the process of response evaluation.
Green tally, pseudo-progression, if the patient is clinically deteriorated, we can't take this to be pseudo-progression. Only if the patient is clinically stable, no drug toxicity, can we go ahead. So that is it. And one point related to PET, if we see a lesion on PET and not on CT, cannot label this as progression. We won't accept that.
I just wanted to ask you, like, if this is the genetic mutation ongoing process, would you like to advise the clinician about the change of the immunotherapy drug in the right time?
Sorry, I couldn't get your question.
No, because because of the increasing mutation, would you like to advise what are the changes in the MR that you would pick up which would enable you to find
on MR, there are a few things, ma'am. Number one is the DC, dynamic contrast enhanced MR, so, which we measure the K-trans, which is a measure of how much of the drug actually goes into the tumor. So that decreases much before the tumor shrinks. Number two, diffusion. Diffusion is a measurement of diffusibility through cells. If there are more number of cells, more proliferating cells, more restricted diffusion. So if the restriction of diffusion goes down, it is a response, even though the tumor size remains the same. Then the measurement of choline, GBM, Jyotika is treating, and the tumor size remains the same, but the choline peaks are much down. I will tell her, go ahead with this response.
Would anyone else like to make a comment? Dr. Sharon needs a mic. Can someone give her a mic, please? Ma'am, can I have a comment, please?
I just want to make a comment here that we are talking about pseudoprogression with the immunotherapy. So there is another this thing in pseudoprogression in radiation. So SRS brain, SBRT lab, we see it all the time. And in fact, it almost goes the same way what the radiologists have just enumerated. So we have to really, take into cognizance of the pseudoprogression and then label it as a recurrent disease.
For pseudoprogression, I would never ever write a pseudoprogression for RT colleague before talking to him or her, because the one biggest point is that in pseudoprogression the patient clinically remains.
No, here the SRS in the SRS goes in the brain. So the patient would have clinical deterioration also, but he would
in pseudoprogression.
But he will respond to steroids. So I think that's the difference between.
How much does the patient?
He can really go bad. At times when there is a pseudoprogression and we are suspecting necrosis, you have to at times get the surgery also.
But that must be, maybe if you're doing 3-4 lesions at the same time, or even with one lesion. Posterior or anywhere.
Anywhere.
It depends on how much dose you are giving. If it's a high dose, SRS treatments, you would see it more than if you are giving fractionated stereotactic radiation. So basically, pseudoprogression is happening because of two reasons. One is there may be a delay in the response of immunotherapeutic agent. Because of that, it is showing a transient increase. And second thing, it may be because of increase in T cells in the tumor area to get the immune response. So because of infiltration of more of T cells, which could be dendritic cells, macrophages or any such thing, and T cells, there could be volume increase.
Yeah, the clinical deterioration may be there with the pseudoprogression. See, it all depends. Even a single lesion can lead to clinical deterioration. It depends on the location of the tumor. That if it is very near to the brainstem, definitely the clinical deterioration may be much more than if it is located in the periphery. And see, especially after SRS, the rate of pseudoprogression is very high. And majority of the patients, they do respond to steroids. Or sometimes, if the lesion is located in periphery and it's not responding, then he may need surgery also.
Can I make a very important point? That is the Raynaud's criteria. I think a very important problem which we face is whether it is a true progression, and patient is very apprehensive when he is asking whether it is a true progression. Even radiologists, they most of the time write progression. So they do not write pseudo-progression as of now. We have seen, despite talking to them, they are very insecure writing pseudo-progression. So I think Raynaud's criteria comes in handy, and we should first use that criteria and fit into that whether the patient fits into, and that patient has to be explained. He can go either way. He can go pseudo-progression way, he can go true progression way, and the only way is follow-up. No more PET scans or spectroscopies, perfusion scans, they don't help. Because most of the time they will recommend do spectroscopy, do perfusion scans. They don't really help. Only the clinical pathway helps, the next 2 to 4 weeks.
In fact, patients who are MGMT methylation positive, they'll show more of pseudoprogression than non-MGMT methylated. And there's, on PET scan also, there's something, they say that if there is a total mean target volume is more than 27 centimeter cube as compared to the previous scan, it might be an indicator. There can be SU lean, not SUV, but SU lean of more than 0.8 is an indicator, and SUV max of more than 15.5%. So there are different criteria criteria which I think as radiologists and nuclear medicine specialists, we all of us and radiation oncologists, we should read all these criteria, because when a patient comes to us and the report shows progression, then it is very, very difficult for us as clinicians to sit in the OPD and counsel the patient and tell that it might be a pseudo progression. So I think we should start mentioning that it could be or more serial imaging is needed, because just one scan cannot give an answer. It has to be a serial imaging, clinical parameters, deterioration of other parameters which would dictate whether patient has a clinical progression or a false progression.
So what's the average time period of pseudo-progression, especially in immunotherapy?
So usually it is around 8 to 12 weeks. So that's why they say you should not do an evaluation scan you should do it after 2 to 3 cycles. So which is invariably around 8 to 12 weeks when you should do the first scan. And then the repeat scan should be at least between 6 to 8 weeks, or the responses would settle down between 8 to 12 weeks later. So I think 2-3 serial scans would help us in getting an answer.
I think that was a wonderful discussion. So the point is talk amongst yourselves and talk to your patient and read out loud. And I think some of the questions in the previous sessions were answered in this sessions. Now I'd request the chairpersons and the panelists to be seated while we start the lamp lighting ceremony. I'd like to call upon Dr. Jyotika Jain, Director Radiation Oncology, to follow the proceedings. Ma'am, if you could please come on the stage.
Thank you very much. It's an honor for us to have our management team over here. So first of all, I would like to request Shri Rajpaji Solanki the first chairman, Venkateshwar Hospital, to please come on the stage. Dr. Y.P. Bhatia sir, advisory chairman, Venkateshwar Hospital. Mr. Kamal Solanki ji, our CEO, Chief Executive Operator. Dr. Nagendra Solanki ji, Director, and Mrs. Gunjan Sinha, CEO. Please join us on the stage for lamp lighting. I would request Dr. Sunil Gupta sir also to join. Thanks a lot for gracing this event with your presence, sir.
Gangana
So carrying on with the third session, now it's time to facilitate our speakers, chairpersons and panelists. I'd like to call upon Dr. D.C. Dover, sir, to carry out the felicitation ceremony. If you could please hand out the mementos, sir. I'd request the chairpersons to come and receive the mementos. Dr. S.K. Verma, Director Medical Oncology, Malin Institute, Dehradun. Dr. Arun Agarwal, Senior Consultant and Director Radiation Oncology, Aadhar Hospital, Sar. Dr. Anupam Mandal, Head of the Department of Nuclear Medicine, Venkateshwar Cancer Center. Dr. A.K. Devan, Thank you, Dr. Dover, sir. I'd like to call upon Dr. Hari Chaturvedi, sir, to please facilitate our panelists with a small memento from our side. Dr. Rakhi, please, if you could come and receive your memento, ma'am. Dr. Lavnish Goyal, sir, if you could please come and receive your memento. Dr. Praveen Bansal, sir, if you could please come and receive your memento. Dr. Indu Bansal, ma'am, if you could please come and receive your memento. Dr. Rashi, if you could please come and receive a memento. Dr. Vedanta, sir, if you could please come and receive a memento. Thanks to our speaker, our chairperson, and our panelists. Can I please call upon Dr. A.K. Anand to facilitate Dr. Anurag Jain, sir? Sir, can I please call you upon the dais? Can you please have a round of applause for Dr. Anurag Jain? I think that was a very detailed and a very comprehensive session and discussion. So now we can proceed to the fourth session. Our fourth session is titled as Any Biomarker Ideal Pathological Challenges in Immunotherapy and Targeted Therapy. I'd like to call upon our esteemed speaker, Dr. Ramesh Tavi, Director Pathology Therapeutic Hospital. Ma'am, if you could please come to the dais and start the fourth session. I'd like to call upon our esteemed chairpersons for the fourth session. Dr. Ashutosh Gupta, Professor Radiation Oncology, Government Medical College, Jammu. Dr. Sachdeesh Jain, Director Surgical Oncology, Mediways Hospital, Ludhiana. Dr. Renu Madan, Head of the Department Pathology, Venkateshwar Cancer Center. Dr. R.K. Kawasra, Head of the Department Surgical Oncology, Rohtak. Can I also please call upon our panelists for the fourth session? Dr. Amit Verma, Senior Consultant, Molecular Oncology, Max Saket. Dr. Sumit Goyal, Senior Consultant, Medical Oncology, Rajiv Gandhi Cancer Institute. Dr. Charu Garg, Associate Director, Radiation Oncology, Max Saket. Dr. Rajiv Kamri, Head of the Department, Histopathology, Lal Path Labs. Dr. Lavnish Goyal, Director, Medical Oncology, Aadhar Hospital, Hisar. And Dr. Geeta Kadia, Director, Surgical Oncology, Max PPG. If you can please have all of you on stage. Ma'am, over to you.
Good afternoon, everybody. I'm going to be talking mainly about biomarkers in cancer and what are the newer developments we can anticipate in these for you. Now, obviously, to understand biomarkers, we should know what are we going to consider as a biomarker. And it's a very broad definition. If we can go to the next slide on these. It's a very broad definition, and practically anything can be a biomarker. Biomarkers came into medicine. Actually, we stole that word from the biochemists. It was originally a criteria that biochemists used to use to talk about the end of a reaction, the end point in a reaction. We've modified it in our part of the world as medicine goes, as that it's any substance or structure, or process that we can measure, that we can characterize well, that we can reproduce each time. If it fulfills these criteria, we call it a biomarker. And basically, it tells us either about the outcome of the disease or a recurrence in a disease, etc. I'll be going into that in a little more detail. It also includes anything that changes because of the treatment we may have given, maybe to an exposure we've given, whether it's radiation, whether it's chemotherapy. We call those also biomarkers. Now, obviously, we almost call everything a biomarker, which produces a reaction in the body. And we can measure it, we can characterize it, and we can reproduce it each time very accurately. The most important thing, I think, in this is the reproduction of these biomarkers. If we can't reproduce them, they're no good. And that's what happens to a lot of biomarkers that initially cause an excitement in the world of pathology and medicine. We think, oh, we finally found a good biomarker, but it doesn't. Now, the important thing about biomarkers is that you have to constantly be evaluating them, and you have to constantly prove their validity. Now, usually validity we can prove as we go along. And once we've produced it, yes, it is valid as a biomarker. We don't constantly do it. But the important thing is reproducibility. And since a lot of these are done on blood and urine and stuff like that, that reproducibility becomes very important. And that's where sometimes labs get bad reputations because different markers in different labs get different light. It's getting better with accreditation coming around now. People are a little more careful with it. With a lot of automation, it's getting to be better because the human factor gets taken away from it. So validity, we don't have to keep doing. But reproducibility, we must guarantee practically. Because if we can't reproduce, could I have the slides, please? Sorry. Can somebody tell me which is this for the slide? No, that's a pointer. I just kind of assume somebody was going to say the slide book for me. It is from the slide. Okay. What I've been talking to you about. The WHO has come up with very good criteria, as I was pointing out, for these markers, what we call markers, and for them to be definitely good for us. Now, I'm not going to get into talking about specific markers. I think many of you are familiar with it. Some of the examples you'll see in my talk are related to breast because we were having a breast session. But please understand these are going to be constantly there for other places. Most of us are familiar with them. Some of the newer markers I'll try to mention to you as we go along. Now, as I said, it's indicative of a cancer in the body, is what we're going to be looking for. A marker should be specific response to that tumor in the body. That can be used. And this is where I think the role of the pathologist has changed, and the role of biomarkers and antibodies, etc., has changed. Why it has changed is we always thought of a pathologist sitting in a corner over a microscope telling you, this is the diagnosis, and maybe telling you, the patient's getting anemic, stuff like that. Today, the pathologist is not doing that. The pathologist is also getting involved in not only helping you decide how your patient is progressing, whether a recurrence is coming, whether a therapy is going to be of use, especially in immunotherapy and targeted therapy. And therefore, markers in these have become very important. Are there any specific ones? Not really. Question is, with personalized therapy and targeted therapy, we are going to have to find these markers as we go along. Some have been found, some have not been found. Is there an ideal marker? Well, by definition, an ideal marker is something that has 100% sensitivity and 100% specificity. Unfortunately, it does not exist. There is no marker around that I know of, and that the literature at least has reported, where you have this kind of fund. Therefore, that's where a panel of markers sometimes is being used. If you use 2-3 markers in combination, you come up with a more educated response. And therefore, it becomes this. Now, I always like to project this slide because the Holy Grail. The Holy Grail for cancer is early diagnosis, a test that will give you early diagnosis, which means that we should be able to detect these tumor cells before the patient becomes asymptomatic. And locate the origin, the location of origin should be 100% accurate. Well, obviously we can't do that all the time. And for some reason it's expected that the pathologist will do it. Well, we try very hard, it doesn't happen. So this is still a holy grail. Will we ever get to it? I'm not very sure. We're getting closer to it. With newer technology, especially in picking up these markers by gene sequencing, etc., we seem to get closer to it, and then we seem to get away from it. I remember when we started using antibodies in immunohistochemistry. Honestly, as a young pathologist at that time, I thought, oh boy, this is going to be very good. And then we learned from our mistakes and realized, yes, we can do it some of the times, but we can't do it all the times. No matter how big a panel. The panels keep getting bigger, the number of markers we use getting more, but the improvement in results becomes a little less as we go with the bigger panels. When we use a big panel, it's usually because we don't have a perfect biomarker for it. These are fundamental things. I think if I'm able to communicate with people, we will understand a little better what's happening. So we're still on the Holy Grail. I've not seen Holy Grail at all. Nobody has defined it. I don't know if we'll get there. Maybe we will. And I'll tell you why I think we may get there towards the end of my talk. Now, why do we use biomarkers? I think most of you are familiar. Detection, treatment, progression, metastases, recurrence, and now we're getting to a point of where we can even talk of developing resistance to your drugs that you're giving, developing resistance to radiotherapy, sensitivity to radiotherapy. New markers are coming in for this. They're still not 100% approved, but we can use them. And most of the markers are easily accessible, either blood, urine, and stool, body fluids, or a piece of the tumor itself. And that has become much better because of our ability to do FNAs, driving biopsies with our radiology friends, and getting into the tissue. On this, whether we do IHC, whether we do other mutational studies, this is where the answers are coming from more and more. Are we getting these answers? Well, a lot better. I can still remember, 6 pathologists sitting together and saying, is this an undifferentiated carcinoma or a sarcoma? And everybody, the clinicians, ready to throw us out because we couldn't give answers. Well, IHC has helped. Immunohistochemistry, antibody studies have helped. And especially the newer automated systems that you have for immunohistochemistry, you can get very good results and interpretation become better. expensive? Yes, it is. And I've been listening to my colleagues talk about other things, immunotherapy, this and that. Somewhere we also have to worry about the expense of the things involved that we're doing. I can do a panel of 15 markers, and come up with a reasonably good diagnosis. But then, is a patient willing to pay it to me? I can do a panel of mutational studies, and I'll talk about a little bit about it later on. Okay, they're expensive. The patient will say, do I really need them? Why can't you just try the drug on me? And patients get impatient about it. They want their treatment started the minute they walk into the hospital. You're all familiar with that. And one time, and I'll talk about that a little bit later, gene mutation, gene sequencing, is time consuming. It took time. Now, of course, automated systems have come in, and we're able to do it much faster. Now, biomarkers, what I've listed here are basically the newer ones that we're looking at. Actually, if you look at it from a technical point of view, ordinary chemistries, etc., were also biomarkers at one time. These also fit into the definition. They just don't have the sensitivity and specificity we need. So we're going into genetics, we're going into epigenetics, we're going into proteomics, we're going into glyconomics, and of course the imaging folks have improved greatly with these biomarkers. Imaging is just as good a biomarker as policy, and it has become even better with the PET scans, etc., and the fact that we can do now very good guided FDAs and biopsies. Those, I think, have been some of the best advantages that we've had in these biomarkers. And I was sitting here listening to everything with the immunotherapy and the targeted therapy. If we can get these pieces of tissue, do mutational studies on them, we can come up with better answers on them. But these markers will help. Now, obviously, the least invasive markers are the best ones, and most of them are in the blood. I think most of you are familiar with, and I've just listed some of the ones we used in the breast. You know that there are plenty of them. Unfortunately, their sensitivity is good, their specificity is not very good. And this is something that I think is important for our colleagues on the clinical side to convey to the patient. Because, as I said, patients today are much better educated, thanks to Dr. Google, and they often will come up with a marker you may not have heard of, and they want it done, because Google says so. And they will listen to their clinical doctor a little better, and you have to explain these are not 100% specific. Same problem arises when we use them for follow-ups. And as we were talking about it, with immunotherapy and these so-called pseudo-progressions, etc., it becomes an even bigger problem. Also, there was mention of the fact that lymph nodes above this size, metastatic, lymph nodes below this, not metastatic. That's radiology, respect it. But please accept that when you come to pathology, sometimes the larger lymph nodes will be reactive. It's the small one that will have a metastatic lesion sitting in. And the number of times we see that at surgery, surgical specimens on FNACs, very important. And therefore, the important thing I think to convey is the limitations of what Now, I was thinking of pseudoprogression and it becoming huge. Can we do an FNAC in it? Can we do a little biopsy in the hider and maybe come up with an answer? Yes, we may be able to do it. And you may be able to get an answer right away. But please accept that there will be times you might just hit necrotic tissue. And that will foul up your system a little bit. So, tumor-associated antigens was something that was very exciting when it was first described. All these lovely antigens sitting on the surface, we can measure antibodies produced to them, we can try to demarcate these antigens. Well, that's what we're doing in immunohistochemistry. But we've learned over the years, we are experiencing it, as we do it much more, hey, sometimes even after doing a huge panel, you may not still be able to give an answer. So, understanding the limitations of the tests that we're doing, because really, I can understand by the time the pathologist gets the material, we are in a situation where we feel a little silly sometimes not being able to give you a diagnosis. But there is going to be a certain percentage. Now, agreed, the further on we go, that percentage gets smaller, but it never goes away. And I think that's probably the most frustrating thing a pathologist faces, is making sure that we get these. Now, tumor antigens, you have to understand, and I'm talking of this because of its relation to immunotherapy and targeted therapy. Targeted therapy, immunotherapy, both. We're not very sure. We know that these antigens will change, but we have not yet got enough material to say what kind of changes will come along with targets. We know, and I'll talk about it in a little more detail when we go on, that as these antigens change, we still have to describe what happens to these antigens when you give them immunotherapy. What happens to these antigens when you give radiation? What happens to these antigens when you give chemotherapy? And this is that whole concept, heterogeneity. The tumors are heterogeneous, and you have to understand this heterogeneity goes on because you've modified it with your treatment. And that treatment is going to make a difference to what the pathologist is going to see on immunohistochemistry, on mutational studies, on gene sequencing, because all these will change with your therapies. And at the moment, we don't have enough. And I kind of feel sorry for the younger pathologists because that's going to be a very complicated affair. And I'll talk to you a little bit towards the end of my talk about what might help us there. To understand this changing scenario as we treat the patient and handle the heterogeneity that's going to come out in sequencing, in mutational studies, in all kinds of studies that we have. And then, of course, a little bit I'd like to talk about the liquid biopsy. It's nothing really but trying to do some of these studies on the blood itself, tumor cells, etc., which I'll talk to you about in a little while. Okay, I've talked a little bit about these things to you. Now, assessing all these things does help. See, you know the various classifications that have come up because of immunohistochemistry and dual classifications that have come up in almost a number of the tumors, especially in the breast, the Galen classification, etc. But these are things where calculation of residual disease, especially in hematological malignancies, by flow cytometry, by these are important. But the details of what happens at the gene level not 100% sure what your immunotherapy is going to do to us gene sequencing. There are studies that have been done on these, but it really hasn't been put together. I was listening to my radiology friend, and I was very impressed with the fact that even responses have been so beautifully classified as far as reporting is concerned. We've done it. I'm sure all of you are familiar with standard Cancer Society, American Cancer Society people have put out how pathology reports are standardized. And over the years, I've seen them improve. I'm sure you've seen them improve. We are using the American Cancer Society protocols for our reporting in pathology. But we still have not gotten into being able to use standardized methodology in response to immunotherapy or chemotherapy. That does not exist in pathology yet. Why? Because we're not even sure of all the changes that are taking place over there. And therefore, I think as time goes by, it will get better, especially now that we're going to be using liquid biopsies for a lot of our follow-ups. I'll tell you how we're going to be doing that. Now the circulating tumor markers, you know what we can assess. And as I said, most of the time, whether it's immunohistochemistry, whether it's circulating tumor markers, we use a panel. But look at the kind of results we get from panels. You use tumor antigens, and you can thought, at least I thought, when I was younger, that hey, the surface antigens, perfect, that's what characterizes the tumor cell. But no, it doesn't. When you use it to detect, it's only 29% of the patients in which you can detect these cancers because of their low sensitivity sometimes. Tumor antigens, tumor-associated antigens in breast cancer, 35%. Not a very happy figure by any standard. And if you look at the control group, sensitivity, 79%. Now you understand the problems with these surface antigens, tumor antigens, which at one time we thought were really going to give us all the answers. Because they were specific. What we had forgotten about and we were not very familiar with was the tumor heterogeneity and the changes that take place in these antigens. And the changes that take place in these antigens because of all the chemicals you've been hitting them with, because of the radiation you've been hitting them with. And that's when, of course, everybody thought, well, then the answer lies within, well, genetic sequencing. And I'll talk about that a little later on. I think the circulating tumor markers, we kind of used as panels and decided what we want to do with. But now I'm coming to the more specific ones, the markers, the biomarkers that we're using on the tissue itself. At one time, immunohistochemistry we thought was going to be good, even on cytological specimens. Unfortunately, that has not been very good. And therefore, most pathologists would like to have a little tissue by piece, even if it's a small piece of tissue that you get. Guided biopsies, I think, are going to be the thing that's going to help us the most. We're using a fair amount of these guided biopsies. And as I was mentioning, we did a whole panel of receptors in the receptor studies. All our reports go out with Ki-67 and Galen classification. Why did we do this? Because I call the Galen classification as the poor man's or the poor country answer to gene sequencing, since it's so expensive. And at that time, it was very expensive, relatively speaking. Some prognosis can be done, and with newer markers that are coming up, even the triple negatives can be further subclassified. Recurrences, we're not very good at with the hormone receptors. They don't help too much with it. And therefore we get into trouble. But the same classification, the Galen classification, can be used to tell you a little bit about the chances of recurrence, etc. And these recurrences can be looked at sometimes with it. There have been a few newer ones. The UPA and the PIA1. These are markers which we've tried to see how aggressive the tumor is. It's a little better than I think the Galen classification in prognosis and in guiding the treatment. And not 100% for whether to say a certain tumor will respond to radiotherapy, etc. No. But this does help there. It's not used very frequently. I think we still need to do further studies with this to come up with an answer for you. Now, all of you have come across these because here I'd like to talk about a little bit about the gap that's coming between technology and how useful it is. So you have to understand that doing all these sequences is a lot of expensive. It's becoming cheaper. Oncotype DX, 21 gene signatures. The only place it is, you can plan treatment with it. You can evaluate for a recurrence. And you can evaluate for metastases. Will the patient do it? But it's expensive. In fact, I remember when they first introduced it, I asked it how much it costs. It costed, I think at that time, $55,000. And I said, hey, how am I going to convince my patient to get one of these gene sequences done? Wait for so long, and then pay in what you might be able to do with therapy with. He still has to pay for that. Well, they have made them cheaper, but they're not that much cheaper. And what we have to remember, I think, with the cancer patients is the cost of what we're giving. I was very impressed with some of the immunotherapies that were being talked about, targeted therapies that are being talked about. But to use these, it's going to cost the patient a lot. And how much are we really adding to what we're doing? In this, where you can afford it, go ahead. And the number of genes, obviously gene signatures has become the password these days. Everybody's talking about it. The big improvement that has happened in all these gene sequencing studies are these new automated things. I think many of us can remember when the human genome, was being done. I'll very quickly go through these slides so I can see what I do. Liquid biopsies, big thing it came when it came, picking up circulating tumor cells, circulating DNA, tumor DNA, circulating free DNA, circulating exomes. It's helpful.
Madam, now can you summarize? Your time is up.
Okay.
Can you summarize?
Exosomes are the big thing now. I'm not sure how far they will go because the advantage of the exomes is that they do have a number of substances in it. They have DNA in it, they have RNA in it, so we can test for a lot more stuff. And the tumor cells shed a lot more exosomes. So studies on these using sequencers might be very helpful. These are some of the newer ones that are coming up. They're still in early phases. Targeted therapies can be done with these. And these are some of the combinations. And this is one thing, and I'll finish up over there. What they're doing now is getting technology and artificial intelligence together. And they're combining these two, coming up with CancerSeq and whole biothese, you know. Atlases are being created from multiple centers. The importance of putting artificial intelligence into this is, like they've shown that with artificial intelligence, you can improve actually diagnosis of mammograms, radiology, and they will be better than the results, because the more data you put in, the better artificial intelligence takes care of it. Why? Because it never forgets. You can put in data from 15,000 patients, and they'll remember it all. And therefore, the interpretation and the conclusions from that become much better. It's what they were saying about artificial intelligence and Watson that came up. They're improving it now, I believe. But I think this is where we're going to have to go, because there's no way we can put these things together. So maybe putting technology and artificial intelligence together will, as we put in more data, our results become better. We might come up with so where is the future in it? I think the future is putting the technology and artificial intelligence in pathology together. Sequencing where data is vast, no human brain can keep it. That's where artificial intelligence is going to help us. There are a number of studies going on right now. As I said, none of these, if they're producing an atlas, you can see it's going on quite far. And there, I think, you will be able to put targeted therapy a lot better. Which one might help, which one might not. Thank you very much.
Thank you, ma'am. That was a rather exhaustive session. So what we'll do now is, in view of the time slightly being exceeded, we won't have any questions in this session. I apologize for the delay, and I'd request Dr. P.K. Sachdeva sir to please come up on the stage and facilitate our chairpersons and panelists. Can I also ask Dr. Jyotika Jain to please come up on the stage and facilitate our panelists and chairpersons? Welcome on the stage, ma'am. Can I please have the mementos? Can I please call the chairpersons to receive the mementos? Dr. Ashutosh. Thank you, sir. Can you please have a round of hands for the chairpersons, please? Dr. Satish Jain. Dr. Renu Madan. And Dr. R.K. Kawasra. Can I please ask the panelists to come and receive their mementos? Dr. Geeta. Dr. Amit Verma. Dr. Targered. Dr. Rajiv. Dr. Lavnish. I thank all the chairpersons and the speaker and the panelists. If we could just start session number 5. This is our panel discussion. Can I please call upon Dr. Davar to receive our memento before we start the 5th session? Thank you, ma'am. That was a very exhaustive and a very interesting talk. Can I please call upon the next session's moderator, Dr. Amish Murasa. Sir is the Director of Medical Oncology at Hope Clinic. Can I please have you on the stage, sir? Can I also have the panelists on the stage for the panel discussion, Dr. Targered, Dr. Geeta, and Dr. Lavnish Goyal. Dr. Mohit Bhatnagar is not with us. Can we please start the next session without much further delay? Thank you, and I please request all speakers in the future to please stick to their times. Thank you.
Thank you. I thank Dr. Sunil Gupta sir for inviting me, and I congratulate Venkateshwar Cancer Center for this wonderful thing. So on the panel we have one surgeon, one radiation oncologist and one medical oncologist. Wow. How do we change this? एक ही बटन है. Okay, we start. So we have the panelists here. The first presenter presented a few of these. I'm sorry, I love taking Harit sir's name. Harit sir, when all these new approvals come in the market, as one of the senior breast surgeons, what is the first thought process which comes in your mind? Oh, one more drug which has come. Oh, now medical oncologists will keep writing. What is your thought? See, if you see in 2019, we have. Sir, you have to say.
I don't want to reply this.
No, sir, I want to reply.
So actually, I trust my medical oncologist very much. So whatever comes will be used for the patient's benefit. That's all I think.
Okay. That's the most non-controversial and apolitical answer. Lavnish, the center where you are, when these drugs, they get the FDA approval, and the next patient walking in your clinic fits into the criteria, what is your approach? Do you change your practice, or the question is, when do you change your practice?
It takes around 4 to 5 years before I can change actually.
Takes around 4 to 5 years.
Before it becomes easily accessible, cheaper, then only. Because most of my patients are cash-based patients and none of them can actually
afford for these.
Only when the trastuzumab biosimilars came, I was able to use them. Rituximab biosimilar came, I was able to use them. So I usually wait for a biosimilar to come, or maybe very good pack, patient assistance program to come. Then only I can use it. Sometimes I discuss with them, but usually I feel if I discuss with them, it only actually creates more problems. Because they cannot afford, so what is the point discussing?
Okay.
Only if they ask me the options, only then I will tell them.
Geeta would love to hear that. Geeta, you have been practicing solely breast cancer for last many years now.
how is your approach towards the patient when you see all these new drugs, or you mentioned that we are very trigger happy as a medical oncologist. Any new patient comes and say, most probably Geeta must be thinking any new patient coming, first 5 patients, put them on those drugs. It's not like that, but what is your approach towards patient? What Lovely said, and I would like to ask any of the people in audience, if you know your patient can't afford, would you give them the expensive option, or would you refrain from giving them expensive option? And maybe this applies to all of us, so maybe Dr. Charu can start, and then Geeta can reply, and then Dr. Gupta also can reply, in his practice, what does he do?
So I think a lot depends upon the affordability. So if the patient cannot afford, there isn't a point like sort of offering them.
You would not offer?
No.
You would not offer, okay.
I mean, but
Geeta?
yes. Offering this, because all this is happening in the metastatic situation.
What do you do in your clinic? If you know patient can't afford, and say alpelisib, if I tell you that it's 19 lakh rupees per month on a compassion.
Not possible.
No. Would you offer or would you not offer?
See, the offering bit does not happen at my end.
Right. But would you like to offer?
I would definitely send her
To a medical oncologist. Okay.
so that they can have this discussion. But if it is, at the point of surgery or something, then I would think, because there is a lot of talk now about very early breast cancer, which should start off with, HER2 positive, start off with trastuzumab and pertuzumab. But if I think that the patient is not the pertuzumab, trastuzumab, and the TDM1 affording kinds, I would say surgery first. See the 3 centimeter tumor, I would say surgery first
So
and then go.
that is what. Dr. Puneet Gupta, if the patient comes, yes ma'am, but before medical oncologist, Dr. Geeta has referred a patient to you, and patient can't afford, would you offer pertuzumab to that patient if the patient is eligible for pertuzumab?
Yeah, what I do in my practice, I actually make it a point, I definitely educate them. So all of my patients, I educate them, this target is available, and he or she is a suitable candidate, then yes, I educate them, and then I also take decision on their behalf. I say it is too costly, and we can, if possible, and if it is a choice of using it next setting, so we always keep that thing open. If just like Herceptin, she told trastuzumab, if it is not like the upfront setting, we are not able to use it, we tell them we can use it at a later date also, or when so that option always remain, because it is not always that if we, many monoclonals, they evolve from metastatic setting to advanced setting, and then to first line, upfront, first line setting. So we can, I always educate them that we can use them at a later point also, but it is always better to use them upfront. But if affordability is not there, I educate them still has the option to use them at a later date.
Later stage.
So that
you educate them. Yes, Dr.
Dr. Amish, I would like to just narrate one small incident. One patient came shabbily dressed in our OPD. So I thought whether I should tell them 3D CRT or should I tell IMRT or IGRT, which is costlier. So I started with 3D CRT and told this is good and we'll try to do the best. At the end, that guy said, what about gating? I've read in the net and you haven't told me about gating. So sometimes we get a deceptive picture and we must tell them what are the options, but perhaps how to individualize.
So, Dr. Charu, you would agree with Dr. Jyotika that you must tell them, let them decide whether they can afford or not?
At times, I think if you tell them and they're not able to afford, then there is a lot of guilt feeling in the patient that they cannot afford. So we've seen that also in the clinics.
We are not moral police here, Dr. Charu. I'll tell you why I'm saying that. There was a complaint against me in Tata Hospital, and the director called me very quickly, and we'll move on to the case. There was this very shabbily looking, as you said, and I didn't give all the options. Patient has given in writing patient's husband, who is Dr. Vora to decide whether I have money for my wife or not. I still remember that sentence almost 12 years back, and I believe he is absolutely right. I apologize. I said, yes, I am nobody, I am not a moral police, I am not an ethical person. Well, not decide about you. After that, I think, what I think is we should offer. It's their choice whether they can afford or not. And we don't know. The looks can be perceptive, and majority of the time they are perceptive, right? Okay. Yes, please. Yes.
It's like Charu said, we should give them the option, And sometimes if the patient is not able to afford, like as a radiation oncologist, I'm saying there's a big note sitting on the, on the spine. I'll definitely do whatever, the easier way of IMRT, I will do that even if I don't charge the patient.
Right.
The patient has to get the correct treatment.
Understood. We have 2 more minutes on this affordability topic and then move on to the case.
I practice in a Tier 2 city, so it's important to get our view also. Daily problem.
Yes, sir.
Totally practice is different, and in rest of 80% of India practice is totally different. So a question of morality, whether you should tell the patient or not for about a particular treatment. First, we should know how much is the benefit you will get.
True.
See, if it benefit is 10%, 5%, and you are telling that person to get that treatment, the question of morality and ethical is totally subjective. It's not objective at all. So what to tell, what not to tell is important. You are important, and you have to decide what to tell, what not to tell. Always patients cannot take the lead. So where you are practicing, whether you are practicing in America, India, Jammu, wherever, it will make a difference. So you can't have a uniform statement for all this.
Right, sir. Point very well taken, sir.
Are we sure pertuzumab and trastuzumab combination gives you an additional benefit of 3%?
See, the question
So
is, in a neoadjuvant setting, in an adjuvant setting, and when you require a response rate versus you are looking at overall survival, the percentages are different. We will not go into the details of that. Point very well taken from everyone. Last point
Just
and we move on.
very small point that after having discussed the affordability of the treatment, please, at that time you have to decide whether he goes for an expensive test at all or not. No point doing an expensive test and then the patient not being able to afford the treatment based on. So that is where the the intelligence of the clinicians comes. Once we ask, we have to do it. But again, this is a very important point, and especially in a country like ours.
Right. All points very well taken. What I understand is that the audience and the panelists, they say that there is no right answer for this. While you are sitting on the chair, you have to decide looking at the patient. I completely take what I do in my practice. I tell whatever options are available. I let the patient and the family member decide. That is what I do. We go on to the case. This is a real case. Sunil sir has just come. This is a real case. The patient's sister was treated by Geeta and me when we were in Max Hospital. So this is a 63-year-old retired teacher. She presented with bilateral breast lump. The left-sided biopsy showed triple negative breast cancer, and the right-sided showed ER/PR negative and HER2 3+ on IHC. On PET-CT, patient has spinal mets. There are no other metastasis anywhere else. The 5 family members have history, or had cancer. They included breast, ovary, and 1 male member with pancreas. This is what the history of the patient was. Actually patient had come to Dr. Geeta first, this patient. So Dr. Geeta, how would you approach this patient? Or you would straight away send to medical oncologist and forget about it?
Because she is HER2 positive on one side. You've not mentioned what size it is.
One TNBC was T1N0M0 clinically, and hormone positive was around 4 to 5 centimeter size. So hormone positive,
HER2 positive.
HER2 positive was a bigger size, and TNBC was just 1 centimeter.
So she does become a candidate for an upfront.
With spinal metastasis? Patient on PET-CT has spinal metastasis, yeah. Only spine metastasis.
Even then, you would start with systemic treatment first.
You start with systemic treatment first. Lovely.
Basically, I will like to do germline mutation also.
You would like to do the germline mutation.
But I will start with chemotherapy with trastuzumab.
Start with chemotherapy.
Yes.
Any other?
Because there is no way to biopsy the spine and know what kind of mets it is. Whether it is HER2 positive or TNBC, we will have to cover the both.
Okay. Same thing. Dr. Sunil, which one would you treat? TNBC or HER2? The patient has bilateral metastatic disease, bilateral CA breast. TNBC we know is very aggressive. The other side is HER2 positive.
My choice in such situation is a combination of a chemotherapy which is effective even in a triple negative patients, covering the HER3+ receptors. My choice is a TCH because carboplatin you are giving for a triple negative and HER2 receptor you are covering this. So my choice in such cases is TCH rather than any other combination.
Dr. Lovely said, Dr. Lovely said that he would do a germline mutation upfront. Is that going to change your treatment pattern?
Just because I mentioned about in the history that there is a family history.
5 family members.
Yes. So I prefer to go for that because sometimes if positive, then your management will be changed.
How would you differ? How would it be different? If I tell you, and this is a real case, okay? We will not go into the details of that. This is the BRCA report for the patient. Okay. So BRCA1 is deleterious. Germline mutation positive and 5 family members. BRCA2 I thought BRCA2 would be positive, but BRCA1 came positive. This is a real report of the patient. Pancreas, breast, ovary, everything, either of them, but BRCA2 I have seen more. But so the BRCA1 positive. Dr. Aparna, do you want to throw a light on this report, only on this slide? Something based on the history so far you have heard?
There are 5 members who have been diagnosed. Again, over here, she's a BRCA1 positive. I would go in for cascade screening, which is test the other family members who could be at risk, both male and female. We tend to ignore the females. We tend to ignore the male relatives. That's the first thing that I would go in and do. And she also needs to be counseled for the fact that she's BRCA1 positive. There is a high risk for ovarian cancer too. So I know she's undergoing breast cancer therapy, but once more that's clear, that also has to be brought up and explained at a later stage.
Right. So after this report, anybody in the audience or Lavnish or Dr. Sunil Gupta or Dr. Puneet Gupta, is your management going to differ? The patient is BRCA1 positive. Is your management in this patient's first line management going to differ?
No, not for the first line.
Not for the first line.
But it is very important for the whole of the family.
But very
important for the whole of the family to know.
To know. Yeah. What if after this report, how would you counsel? Because I see this patient when it came with this BRCA report, I also did the same. I said 5 family members, germline mutation to karna hi karna hai. Patient came with germline mutation. By the time I had started the treatment, how does your counseling change in this patient? Do we have the enough knowledge to change our chemotherapy based on BRCA report? Right now, in 2020.
We have option for that. Olaparib is there.
Okay. Now this patient, in addition to BRCA, PD-L1 15% positive by TPS. DACO platform by. Now, the question is...
This is for the TNBC or the HER2?
I don't know that.
You have to tell them.
PD-L1 was on TNBC.
On TNBC?
Yes.
So that is
PD-L1
expected.
was on TNBC. HER2 I did not do PD-L1 because they are exclusive. So we have a patient, 63-year-old patient, bilateral breast, metastatic disease, symptomatic for spine, BRCA positive, PD-L1 positive, one tumor is TNBC, one tumor is HER2. What would be the treatment choice now? Would anybody give different treatment? Assuming BRCA report is not there, assuming PD-L1 report is not there, would your treatment change? My question is that we do BRCA and PD-L1 by reflex, but is that management going to be different? There is no data on first line metastatic. Lovely, you would agree with that?
For TNBC we have 1% more at AZO with nab-paclitaxel. Trial is there. Very good responses. No.
So
OS was
we will come to that. We have the data for that, and NCCN guidelines has incorporated one of the options. So before that, in fact, I thought Amit would be here. Dr. Aparna, are HER2 and BRCA2 exclusive diseases? Can they occur in the same tumor? Or anybody who's from the molecular pathology background, do HER2 and BRCA, are they exclusive? Can they occur in the same tumor? Here we don't know because there are 2 different tumors, 2 different biologies, which is proven, but are they exclusive?
I've actually seen cases where we've had HER2 negative and BRCA positive and HER2 positive and BRCA positive. So I have these cases, so
You have these cases?
I have these cases, so based on the data that's available in our office. Yes,
Okay.
on germline, BRCA germline also.
BRCA germline and HER2 on tumor.
Correct.
Okay. So this was Mayo Clinic data where they did not have a single patient which had both positive but Dr. Aparna does Xavier. UK audit, 2.2% of the patients had both HER2 positive and this both. So this particular patient refused TCH, Sunil sir. Patient said she had 1 year extension in the school. She said with TCH I would be homebound, I do not want to take. She opted for weekly paclitaxel plus trastuzumab. She refused for pertuzumab. I gave pertuzumab option for response rate, but when I told the overall survival difference, she refused for pertuzumab. After 12 weeks, patient responded very well. Refused for anthracycline-based chemotherapy further, even though scalp cooling was effective on her, but she refused for anthracycline. Next what? Lavnish, 12 weeks over, responded well. What would you do further?
I'll do trastuzumab with oral capecitabine.
Trastuzumab with oral capecitabine. Anybody in the audience, any other thing they would treat?
No hair loss, and you can continue the Herceptin.
Right, okay. So, we continued Herceptin only, not capecitabine. For some reason, I didn't call Dr. Lavnish and I gave only trastuzumab maintenance. Within 6 months and I think 6 to 7 months in between, the tumor on triple negative side increased. Not on HER2 side, but triple negative side from 1 centimeter became 5 centimeter. And on PET CT, there was one liver lesion. Patient complained of excessive sleepiness. I got the MRI brain. MRI brain was normal. Now what? Patient received paclitaxel plus trastuzumab, followed by trastuzumab. The HER2 side responded, still responding, but TNBC side started increasing from 1 centimeter became 5 centimeter. Lavnish, what would you do?
What about the liver lesion? Is it asymptomatic?
Liver lesion was too asymptomatic, LFT normal. No visceral crisis. But this size increased.
So we have two options. Either if the patient can afford, olaparib can still be tried because already chemotherapy has been given. Or second option is again re-challenge with the chemotherapy.
Re-challenge with chemotherapy or olaparib means the BRCA can be revisited here. Would you give olaparib or anybody would give olaparib at this stage? Any medical oncologist in the team? Try gemcitabine carboplatin.
Yes, actually there are so many options. Gem carbo, as Tosh mentioned about, even for a triple negative, my specific word is triple negative, eribulin is one of the options as a single agent. Means once you are talking about a triple negative breast cancer patients. The issue is that it's an individual medical oncologist discretion regarding selection of chemotherapy. As Tosh mentioned,
she would require second line chemotherapy. Actually, sir mentioned eribulin because finally patient went on eribulin, but I would like to ask.
Can I ask you one question before you ask?
Yes, sir.
Yeah.
Sir, please.
Yeah. So, no, I want to ask one question. So, on presentation, she had oligometastasis in the spine.
So, 3 spine lesions, you can call them oligometastasis, yes.
So there is one thought that, I've been presenting in my presentation also. SBRT to spine, even if they are asymptomatic, has an advantage because not only it has a local, the chance of local progression are reduced, but it has immune stimulatory response. So I think nowadays I will show you the data that should have been done according to me.
So SBRT to asymptomatic spine metastasis should have been given. Dr. Charu, you are not with Anand sir working, you are an independent panelist. Would you agree or would you criticize that point?
If they are not symptomatic, I would wait for the systemic treatment to start.
You would wait for the systemic treatment then. Dr. Jyotika, would you give SBRT to asymptomatic spine meds in this patient or would you wait?
Suppose they are going to produce some effect in near future, impending things there. Suppose any lesion which is very nearby to the cord, and if you are giving therapy and in the meanwhile tumor progresses, definitely I would.
Definitely. Sir?
Pain.
Right.
We are talking of immune response.
Immune response.
So it's a systemic response we are
systemic
talking
response.
not
For that you are on the point well taken, sir.
I will agree with Dr. Anand. There is one more advantage, and because the location, if you look, if there is, the axial skeleton is involved, it is better not to wait for symptoms to arrive because the body weight transfer happens through that. So I think I'll second Dr. Anand.
Right. So saying my time's up, 5 more minutes, not more than that, otherwise the time would be delayed. Sir, since you were standing, would you offer immunotherapy to this patient? More than 6 months passed, Taxane has not been given, Taxane responded earlier, patient can afford, would you offer nab-paclitaxel plus atezolizumab based on this trial?
Sure. It is, I think, a good combination, and if the patient affordability has been really good, I could have offered it upfront.
You could have offered it upfront also.
Yes.
Okay. So, Dr. Geeta, we have the data of showing that one of the thing is in the entire cohort of PD-L1 positive and negative, overall survival was not different. But PD-L1 positive, which this patient has, overall survival was different. Very quickly, I will go to next. So, sir, patient received eribulin. After 4 cycles, there was a good response. After 6 cycles, patient had such a great fatigue, patient refused, I am not going to take eribulin further, I am going to stop. So we stopped, gave a break of 2 months, but patient came after 1.5 months, and again the tumor size was increased, the liver lesions increased. Patient was given the option of TDM1, lapatinib and capecitabine at this point of time, and gem-carbo. Also was explained NGS, which would be a good way of looking why her disease is behaving like this. So that would be my last question to panelists, because otherwise this will go on and on. Ravneesh, could this patient have any other mutation which can be deleterious, which do not respond to anti-HER2 treatment and chemotherapy?
Difficult to tell now. It's difficult to tell.
Difficult to tell. Anybody? Oh, I wish Amit was here. So, till 2 years back, yes, Dr. Aparna, till 2 years back, please tell me if I am right or wrong, we are running short of time. I also thought the same, the driver mutation does not change, but they do change. That is what now the world is experiencing. And this patient, actually I am waiting for NGS report, but when I was reading, this patient may fit into PIK3CA mutation positive. Am I right?
Absolutely.
Right. The PIK3 mutation positive means they will not respond to anti-HER2 treatment, they will respond less to chemotherapy. Only advantage is alpelisib is available. Unfortunately, the FDA approval is alpelisib with fulvestrant because they have done the trial on ER positive patients. So what I am trying to say is that the upfront knowledge of BRCA and PIK3 is going to help us in future to know which treatment to give and which treatment not to give, and that probably may be the future, the way we look at it. If nobody has any questions or any, yes sir, my role is done, my job is done, now we ask.
He is totally resistant to chemotherapy now. So as per this, she is totally resistant to the conventional chemotherapy. So is there a role of androgen receptors and some androgen agents?
Sir, I did AR is negative in this patient.
I like to convince the lady for anthracycline because TNBC respond very well to TNBC, and forget about hair fall and all, and at least take care of her life before adopting other procedures, other chemotherapy.
So you would offer either adriamycin or liposomal doxorubicin based chemotherapy. Okay, point well taken. Patient was counseled. I understand patient had refused, but point is well taken. Anybody else? Otherwise, we can wind up the panel. Yes, Dr. Puneet.
Only one thought that, if I had sometime a patient across like this, let's say hybrid leukemias, we have AML plus ALL. So basically, more aggressive the disease, so you will treat AML or ALL. So we say, okay, treat AML when it's more aggressive. Similarly, here we have HER positive disease and triple negative. Do you think it could have been a good strategy if you could have treated it upfront with atezolizumab and paclitaxel like stuff upfront?
I have the knowledge that BRCA and HER2 are normally non-exclusive. They are exclusive. I did not have any knowledge at that point of time that immunotherapy in HER2 positive tumor, how well they behave. I had explained to patient about this trial, because by that time this trial was out. I had explained, but I also said I do not know that in a HER2 positive patients the role of immunotherapy is what. Now we know, now the picture are clear, but at that time I did not know. I said it would be safe for me, as Dr. Sunil said, to combine chemo with trastuzumab to use. That is what I felt is the best way to do. Thank you very much. Thank you, sir. Thank you, all the panelists.
Thank you, sir, for completing the panel discussion on time. And I thank the panelists for a very fruitful discussion. We will now begin our lung session. So our first session of lung cancer is titled, What are the appropriate considerations post-immunotherapy and target therapy for surgery? And it is my honor to call upon Dr. Hari Chaturvedi, sir, Director Surgical Oncology, Max Group, to start the talk. I'd also like to call upon our esteemed chairpersons for the session. Dr. Jyotika Jain, Director Radiation Oncology, Venkateshwar Cancer Center. Dr. Dinesh Katyar, Senior Consultant and Director Surgical Oncology, Venkateshwar Cancer Center. And while we are calling everyone, can we please have Dr. Amish Vora and the panelists for their memento presentation. Last, Dr. Sri Gupta, sir, to present the mementos. Thank you, Dr. Amish. That was a wonderful discussion. I'm sure everyone enjoyed it. So continuing on, we'll continue with the lung session, session 1. Can I please call upon the speaker, Dr. Hari Chaturvedi, Director Surgical. Thank you, sir. Can I please call upon the panelists, Dr. Kumardeep, Director Medical Oncology, Fortis Noida, Dr. Sandeep Agarwal, Senior Consultant Radiation Oncology, Max Vaishali, Dr. Jalaj Bakshi, Senior Consultant Surgical Oncology, Fortis Noida, Dr. Tushar, Senior Consultant Gastro-Oncology, Venkateshwar Cancer Center, and Dr. Rajendra Kumar, Director Radiation Oncology, Fortis Shalimar, to start the session. Over to you, sir.
Thank you, Bharat. Thank you, Sunil and Dr. Jyotika and the Venkateshwar team for having us here. I think first I should clear the air. Amish Vora is here. He's left already. I think he's left. So he told me why you made an apolitical statement, that why you said that there is no other emotion involved when you look at these new prescriptions and new drugs. So actually my answer is very simple, that actually we all don't know what is happening around us. So as a surgeon, I rarely know what is the real development in medical oncology, immunotherapy, all these spaces, and likewise in radiation, all that. So it's very important for us to be respectful and to be kind and to be open-minded to what is happening around. And that is why we should not be prejudiced and start questioning every move from every colleague. So that is my pure intention, and it was not an apolitical. That's what I believe in, and that's what helps for all of us. So I think in last 1.5 hours when I was waiting, I have really learnt a lot, and that was one reason why I accepted this talk immediately. I said this is something which I want to know more and more, and it's so rapidly evolving that we really do not have a control on, and we have seen such developments everywhere in all specialties. So the topic given was considerations for surgery post immuno and target therapy. So that means basically the role of neoadjuvant immuno and target therapy and how the surgeons are looking at it. So the way I look at things, the kind of new words which has come into play, I have learned so many new words in last 3-4 years as far as molecular immunospace is concerned. It's very important for even the surgeons and the radiation oncologists to get more and more used to these words. Today I learned a new word called MPR, Maximal Pathological Response. Yesterday I had something else, and one AIMS A3, AMES A3, which I went on the Wikipedia to see what it means. This I read 2-3 days back. So the point is that so many new things are happening. The first and foremost, all of us need to have a understanding of what is going around, otherwise we miss the real content and the meaning of that. And definitely there is an evolving role. I would even go a step forward and say, in fact, immuno and targeted is now mainstream oncology. It is no more something in question or something which will evolve and come into being. So it is mainstreaming of has happened. It is important for us to really actively involve and not suspect that there is something less impactful. There are large number of trials already going on. Like in all areas, everything starts from palliative setting, metastatic setting, then goes on to adjuvant and then to neoadjuvant, and you don't know what will replace what and how the roles of others will get evolved, where the surgeons will get, in fact, for example, in a metastatic melanoma, I had never imagined that a metastatic melanoma will survive for 3 years and the patient will come to me with a small residue. This has happened in my practice already. So likewise, all of us keep evolving and this keeps happening. So there is active usage of immunotherapy in real life clinical practice in all our domains, and there is a definite evidence that pathological CR is growing. This is a lung cancer session, so I will just briefly touch on lung. Pathological CR is growing, and that is a surrogate marker of survival. So we should take with an open mind that probably it will have a role to play. Now this is just a brief chart how things have evolved. I just want to emphasize on the last 5 years. Today is the first week, end of the first week of 2020. If I look at from 2015 onwards, so many things have happened, and also happened in the space of neoadjuvant therapy and immunotherapy, which I had not known if I had not asked for this talk. Only for this reason I went through all this and then realized that really it is mainstreaming of neoadjuvant therapy is happening in immunotherapy. And even in ASCO last year, there was some presentation on this, which led to presentation of data on immunotherapy. Now, what is the rationale for this? Why mainstream of immunotherapy or why neoadjuvant therapy? Now, this is the tumor cell. On one side, in the green, what are the benefits if you give neoadjuvant therapy? And in the red are the questions why it will not work or why it should be suspected. So, in the green, if you see, when you start a neoadjuvant, there are a large number of tumor cells, antigens available. So, it leads to a lot of cross-priming by the immunological reactions. So, immunotherapy works better in that situation. Number two, there are more tumor-infiltrating lymphocytes, and that again leads to more and more priming of the tumor cells and availability of tumor tissue for better intratumoral approaches. On the red, again, now this is the pros or the advantage of starting with neoadjuvant. Whereas they say if you start with immunotherapy, just like they have too many antigens, they have also got too many suppressive antibodies in the tumor cells. So it will not going to work. And cells in the tumor stroma is also present. So both the things, they have some benefits, and so like we all talk about EBM, finally the evidence has to prove what is playing a major role. But as far as biological understanding is concerned, there are certain benefits of starting with neoadjuvant because of tumor cells, and we also know that lymph nodes have a critical role in the immunological balance in the tumor area. And what happens in these tumor cells, that when you have lymphatic migration of immunogenic antigenic antigens, that means the antigens are immunized and they are migrating. That also leads to better circulation of these cells and better reaction from the lymph nodes. The tumor-drained lymph nodes are the basically immunogenic approach is there from there. Likewise, in surgery, when we remove all these lymph nodes, then it will have a negative impact, so to say. Even in neoadjuvant setting, you give this immunotherapy you start, that will lead to better stimulation of these lymph nodes and the lymphatic tissue and leading to better circulation of these cells. Whereas those who counter this, they say that lymphatic migration of iatrogenic antigen-presenting cells. What is happening as you are giving immunotherapy pre-operatively or neoadjuvantly, the resistant clones will get into circulation. So they say that you remove the tumor, you will have less tumor cells, less antigens, and you will have more better antibodies to work. Now, so we will see what the evidence is. So this is the complexity. On one side, people say that neoadjuvant gives certain benefits, other side people say neoadjuvant has disadvantage. What is the real evidence? So first and foremost, are the surgeons willing to do surgery after immunotherapy? That is the prime question. Because we all know how chemotherapy, radiation, when chemoradiation came into being, a lot of us surgeons were very hesitant on taking these patients because complications will go and things like that. Whereas now we realize gradually that actually after you do CTRT, whether you do esophagus or rectum, the surgical planes are better, the outcomes are better, everything goes better. This is one of the first few studies on feasibility and safety of surgery in patients after immune checkpoint inhibitors retrospectively. They studied 17 patients who had undergone 22 surgeries, and they found that there was no increase in the complications of any kind, neither bleeding or recovery or anything. In fact, it was all quite effective and as safe as compared to a randomized other surgical group. Similar thing in lung cancer specifically. Now, this is also a study where they said that there was a good response to chemotherapy. There was few side effects, did not delay surgery, and induced major pathological response. Here also the complication rate did not go up. The point is that post-immunotarget therapy, surgery is safe and acceptable. However, there are a lot of questions. What is the timing of surgery? What is the evaluation before surgery? Whether the patient is fit for surgery? Whether prone for any complications like endocrine complications or things like that? Those questions remain. That is not sorted completely. But as far as major complications concerned is regarding anastomotic or anything else, there is no such thing. Now, what are the indications now? In present context, as we are seeing the role of immunotherapy, and the previous session had a wonderful case on breast cancer, which patient was treated with target drugs. In colorectal cancer today, we know that it is routine to offer surgical resection or RFA or SBRT, depending on situation in the location, post chemotherapy. Likewise, post targeted drugs and immunotherapy also, there is a definite role and indication for surgery in colorectal cancer. In renal cell carcinoma, it has gone out, come in, and things have gone on and on. But there is definitely a role of surgery for the primary tumor post TKIs when the symptoms appear from the primary. If it is under control, then this is a space where surgeons have to take a decision how to operate, when to operate, what are the concerns. In melanoma, I just mentioned that there is a wonderful response in a lot of patients, and we don't have too many melanomas, but I have experience with lung patients. I had a great response going on for almost 3 years now. And typically in this literature they have mentioned metastectomy suggested for immunotherapy disease. Some area which is not working, remove that area because that will not respond to immunotherapy. Now the question is how to identify whether it is really refractory or you are evaluating too early. This is not well understood. Today they are saying post 12 months consider surgery. That is the recommendation. Likewise in breast cancer, just now we heard, and in fact Amit has also left. Amit just now mentioned to me that he's already put one of his known relatives of breast cancer on urgent immunotherapy for breast cancer. So this is how, this is the evidence which I was going to talk about briefly, that this is a higher pathological complete response rate is already there if you combine chemo and immunotherapy through the study of Keynote 522. Now this is the status that already there's evidence is there, pathological complete responses have gone up, and this is going to, and in the subsequent study, in the patients who were node positive, the response rate was even 64 versus 44%. That's significantly high. And there was no difference in side effects or any other adverse effect compared to a group which has only chemotherapy. So whether you add chemotherapy with immuno or chemo alone and subsequently operate, the side effects are same, the company is same, but the responses are better. So I'm sure as we discuss, it will get mainstream gradually. And Amit just now mentioned that already he has put one patient on immunotherapy for breast cancer. Similar evidence is in lung cancer. That whether stage 1 to 3, lot of situations we start with urgent chemo and then operate depending on. Again, they have done small group of patients have had surgery post immuno. Again, the complication is not higher. Maximal, this is where the MPR and the PCR. Normally we talk about pathological complete response. Here they say major pathological response. That means the residue is less than 10%. That's a major pathological response. Even this group will behave much better compared to the group which has more than 10% residual disease. And in, again, lung cancer, again, there's been a definite benefit being seen as this group is growing. Now, these are a number of trials already going on in lung cancer where use of immunotherapy is incorporated as neoadjuvant therapy. Now, this is how things will change. As this will unfold, the trials will get completed. There are lots of issues related to the evaluation and the integration of team. But what we foresee that we will have a solution as a collaborative approach. Obviously, the surgeons at the time of, and the patients obviously are worried about how this will impact the surgical procedure, like adhesions, hemorrhage, impaired wound healing, what will the impact, reactivation of infections like hepatitis, as if the patient gets immunosuppressed, what will happen to other diseases and infections, that anastomosis at risk, endocrine and cardiac abnormalities. We know that immunotherapy has a lot of implications on endocrinology and rheumatic and pulmonary issues. So that also how it will affect the preparation of the patient. And I will also talk about the evaluation post-surgery, because we know the evaluation is also difficult. Now anesthesia, fitness, and how do you prepare these patients, especially lung cancer patients who undergo immunotherapy, where we know their pulmonary endocrine complications are expected. There you have to prepare these patients for surgery. And what is the best timing of surgery? So early evidence is that there is no increase in surgical complications. The recommended time today is 3 to 4 weeks, just as for chemotherapy. However, people are doing as soon as 1 week and also up to 6 to 8 weeks, but this is not sorted completely and is something in domain, but it is something which is possible to do. We all know in bevacizumab, we do 8 weeks waiting, in TKIs even 1 week, and HER2 and other we operate 1 day, next day after giving us a treatment. So all these things are there. The real challenge is that we have to really have more evidence and more confidence as we handle major cases. In minor cases, people don't care much, but in many these things will become issue and they need to be really, really understood. Now, response assessment before surgery is one very big challenging area. These are a couple of slides from lung cancer, for example. The imaging before immuno and after. If you look at the upper corner, so if you look at this, there is a good response before surgery. And here in this other case, there seems to be a progression. Whether in pathology in both the specimen, the response was more than 90% response. So the imaging was not reflecting what was true evidence. And something about pseudo-progression was mentioned. Similar thing is being noticed here also, that on imaging we are seeing that there is a progression in disease, but in pathology it has responded and there is less disease. So these are things we have to grapple with and we have to find solutions, and we will have something more to say. So if I have to talk about neoadjuvant immunotherapy and surgeons, I think time has come when this integration will happen and mainstreaming is happening. We don't have to worry. There is enough evidence emerging where surgery is safe, surgery will be effective. We have to learn how to evaluate preoperatively, how to prepare the patient better preoperatively, and how to make sure that we are choosing the right patient for the surgery, where to identify the resistant clones or the ones that are not responsive and things like that. That will happen. But it's an evolving phase and we will have a definite role. There is another opportunity with surgeons and immunotherapy. There is another evidence suggests that post-surgery, today you operate, the second, third post-op day is a time when there is maximum immune response in the body related to tumor and the host. And this is typically reflected, as I say, reaction to surgery and things like that. There are a lot of things happen in the body just because of anesthesia and surgery, the intervention. So there is an opportunity here to institute immunotherapy immediate post-op. This is beyond what is neoadjuvant, but immediate post-op, and that may give us better survival outcomes and things like that. This scope where this work is going on, that there is a time where maximum immune response or disturbance happens in the body and one can leverage that to take it forward. So if I have to summarize, I will say there's early data on this, it is safe, it should become a common scenario in the clinics in very near future. What we think will happen in 5 years will actually happen in 1 year, I think, and it is going to happen. There's careful multidisciplinary integration is required. These things should not be on an ad hoc basis, should be planned, due diligence, and then only get into it. And there's a lot of scope of research, and we also can play a significant role as evidence will emerge in this. Thank you very much.
Thank you, sir. I think there were numerous very interesting perspectives in that presentation. Any questions from the audience for the chairperson, the speaker, or the panelists?
Sir, have you ever operated any like EGFR as mutated patient on targeted therapy in lung cancer? Have you operated on
in lung, we have not.
Lung.
We have not done. Because generally metastatic is a palliative surgery. Now as we do mainstreaming probably.
Yes.
Any other comments from the audience? Any questions? Dr. Puneet, can you please summarize your mic?
So thanks, Dr. Harith, for making us aware of these newer challenges. In lung cancer, I'd like to continue as you have told. There is that's a tough population, and especially in EGFR mutated patients. You know, it is there is no benefit of drugs like Keytruda and others. So here, you know, the good role of surgery is in place. And as Dr. Harith has highlighted, you know, if there is EGFR mutations and this even Keytruda, the best immuno-oncology drug doesn't work, there is a definite more role of upfront surgery coming up. So this is how I think we have to integrate these things. And another point is also the higher understanding of immuno-oncology, especially if you see now the challenge of we are selecting when we use Keytruda, we have to know whether the patient is EGFR or ALK mutated or not mutated. So if they are, the selection is based on that, and response rates are also based on that. And patients who are EGFR and ALK refractory, so beyond even Keytruda doesn't do good on these failed patients. So newer drugs, HMM2 inhibitor and another, the drugs are coming up. Now newer immuno-oncology is coming up. But definitely, there again, in that subset of population, I think role of surgery is definitely there. Thank you.
Thank you so much for that interesting comment. Does anyone else in the audience have any questions? No. Alright, then I think we'll close this session. I'd like to request Dr. Kuldeep Sharma, Senior Consultant Radiation Oncology, to please come on the stage and facilitate our speakers, panelists and chairpersons. Sir, if you would please come on the stage. Could the chairpersons please come this way to see the mementos? Could the panelists please come and receive the mementos? Dr. Tushar. Dr. Rajendra. Harit, sir. Could you please come and receive your memento, sir? Thank you, sir. That was a very interesting talk. Thank you, respected chairpersons, panelists, and speakers. So, without much further ado, we'll start the next session. The next session is titled Role of Immunoradiotherapy and Targeted Therapy in Locally Advanced Lung Cancer. And I'd like to call upon the speaker, Dr. A.K. Anand, Director, Radiation Oncology, Max Saket. So, if you could please have you on the stage. It's an honor to call upon you to present this talk. Can I please have the chairpersons for the talk? Dr. Munish Gorala, sir, Director, Radiation Oncology, Rajiv Gandhi Cancer Institute. Dr. S.K. Verma, Director, Medical Oncology, Himalayan Institute, Dehradun. Dr. Dinesh Katiyar, Senior Consultant, Surgical Oncology, Venkateshwar Cancer Center. And Dr. Malay Nandi, Director, Medical Oncology, JP. Can I please call upon the panelists for this session? Dr. Rajat Saha, Director, Medical Oncology, Max PPG. Dr. Amit Jain, Director, Radiation Oncology, Varentis Hospital. Dr. Swarupa Mitra, Senior Consultant, Radiation Oncology, Rajiv Cancer. Dr. Rajesh Jain, Senior Consultant, Surgical Oncology. And Dr. Tushar, I'd like to call you upon once again, Senior Consultant, Surgical Gastroenterology, Venkateshwar Cancer Center. And I'd also like to call upon Dr. Kuldeep Sharma, sir, to be a panelist in this session. So if you would please come on the dais, so we can start the session. Over to Dr. A.K. Anand, sir.
Good afternoon, everybody, and hopefully it's a pre-lunch session, so wait for a good lunch after this. And I think we had very good session in the morning regarding immunotherapy, including some case presentation and overall what immunotherapy is doing. But I think immunotherapy is also multi-modality kind of therapy, which should involve not only medical oncologists, but also surgeon, as you saw from his talk. And I am also now going to speak how radiation interacts with immunotherapy and how we can achieve maximum responses with immunotherapy by integration with other modalities. I think that is my message for this, that immunotherapy by its own can have much more better effects if we combine and think of combining with other modalities of surgery and radiation. Radiation affects the immune system. It is a modality which not many of us know, but it is a very potent modality which can affect cancer initiation, progression, and pathogenesis. And radiotherapy, especially when we give high doses of SBRT and SRS, can have immunogenic effect by way of it can stimulate anti-tumor T cell population, and I will show you the mechanism by which it does, by promoting the antigen-specific dendritic cells, increasing the numbers of CD8 positive T cells which are involved in our immune mechanism and immune system. So therefore, very surprisingly to us, when we read about this, these slides are about 5-6 years old when I had one talk in Mumbai, at the time we prepared, the systemic effects were seen with a dose as high as about 20-25 gray, which we give with SBRT in hypofractionated regimens. We saw systemic effects beyond the local effect. So wherever we gave radiation or that local site, there was a systemic effects in the rest of the body. So this was through the increase in T cell response, which I will show you in the next diagram. So radiotherapy contributes to a very important statement. It contributes to making tumors visible. So when the tumor is progressing, our immune system is sleeping. That's why tumor is progressing. So radiation, by releasing certain cytokines, makes these tumors visible to our own immune system, so that the immune system starts working. So it can induce secretion of a wide range of cytokines, and I will show you in the next diagram. And the radiation-induced necrotic cell death leads to release of cytokines of various types. Like here, in the yellow you can see radiation on a tumor cell which is dying, which is releasing all these cytokines here, dendritic cells, and then they move these T cells towards the tumor, not only locally, but also wherever there is a distant disease, whether macroscopic or even microscopic. So here it is shown that after the release of these cytokines, when you give radiation to this site, so there is a local response, of course, with the SBRT, but a bystander effect takes place around it, so that the local relapses are very rare because of the addition of SBRT. And then you see a distant response in some other organ where radiation was not even given. So these are the this is the kind of the mechanism by which the anti-tumor immune response happens, and it involves 3 steps: T cell generation. Then there is a T cell has to infiltrate in and around the tumor, and then there is a T cell killing through the mechanism as I just told you. So I will go to the next slide. So this is a mechanism why it's showing that there is a, for immune desert, you have to have driver antigens to wake up this immune system. Then these recruited T cells should go, and not only the tumor but even the stromal, peritumoral stroma is affected by these T cells, and then it goes into the redirect these cells and T cells in and around the tumor. So therefore, in summary, we can say that the radiation has a direct side effect, we all know that, but it also has a stress response, an immune response after the release of the cytokines. And I said that there is a bystander effect in the tumor vicinity also, where we are targeting with high dose of radiation. But a very surprising effect is the abscopal effect, where the effect is in the non-radiated tissues which are far off from the area where we give radiation. So it is typically seen that how much dose of radiation should be given. Usually it is recommended to give high dose, and I don't know how to go back. How to go back? Previous slide. Oh? I don't know how to go back. Previous slide. Okay. So these are the, so when we are looking for radiation immune responses, then we have to look for host responses, the tumor responses, and the treatment characteristics, what kind of treatment received before and what kind of treatment is happening. So these are the doses as I was mentioning. So preference is to give high dose hypofractionated, like 20 grain 1 fraction or 8 grain 3 fraction, and then you will see better immune response. So this I will just, for the audience, I will show you one case report about the abscopal effect, which will tell you that it is a real thing, it is not just a description. This is a patient who had this they had a hepatocellular carcinoma on the liver, and a high dose of radiation was given to the liver. So this is the liver tumor, you can see, and a 70 gray in about 8 to 10 fraction was given to the liver tumor. But what happened? The liver tumor shrunk, it responded, but what happened to the lung metastasis? These were the lung metastasis before radiation to the liver, and these are the lung mets after radiation without any systemic therapy. So these kind is called abscopal effect and is well known. The challenge is how to make it happen more often, how to predict abscopal response, what we can do to increase the incidence of these abscopal responses. So, as I said before, so this is the radiotherapy generates anti-tumor immunity. It is due to the immune suppressive. So the abscopal effects are not seen very frequently because of these cells, PD1 and CD4 receptors. Now we have drugs which act against them. Anti-PD1 and anti-CD4 drugs are now fortunately available. We can use these drugs and can increase the immune response. So there is a natural collaboration of radiation with this anti-PD1 and anti-CD4 combinations, and local responses to radiotherapy then can become more predictive, that the systemic responses will be more predictable. So this is very nice publication, and it's just the gist I saw here, and you can see that the participation of endogenous immune responses in modifying radiation effects have been widely documented, and at that time they were saying more of clinical, but I have now shown more of a lot of clinical material also of integration of radiation as a immune modifying agent and in combination with immunotherapy. So let us talk of non-small cell lung cancer. Stage 3, current status we know, concurrent chemoradiation is the treatment of choice, and it yields high local control rates. And then you can see that even now, if you see across the country, this debate about concurrent versus sequential is ever-raging. Nobody still believes that concurrent chemoradiation is the treatment of choice. Many centers are picking up now, but still we have to enforce, and the long-term data is available saying that there is a 2-year, 3-year, 5-year overall survival benefit with concurrent chemoradiation rather than sequential. So wherever possible, avoid sequential, and it should be the concurrent. So here, even when we use triple therapy, surgeries and all that, so in all this big, the publication, you can see there's no superiority of trimodality. No point doing pre-op chemo, then surgery, then post-op radiation. So that doesn't help beyond the concurrent chemoradiation. So radiation oncology, there is now, so why I'm talking about the technology? Because we are scared of radiation side effects in combination with immunotherapy. So with this technology, now we can deliver radiation very confined to this tumor. You can see here, and so we can save the lung a lot, and therefore the radiation pneumonitis rates are really low now, and we can combine with the concurrent chemotherapy and then immunotherapy. So this is the kind of post-chemo radiation effects, scarring, and otherwise a relatively healthy lung all around. So the IMRT benefit is that it has reduced the pneumonitis rates considerably. So now we can combine immunotherapy, and I will show in all the trials, which has now become a standard of care. So radiotherapy and immunotherapy stage 3 non-small cell lung cancer. You see, this is the trial. Everybody I think must be knowing about this trial published just about 1.5 years back. Pacific trial. Sorry, again I have done this. Anyway, so you can see here, in this trial, patients had, can you go back? Patient had concurrent chemoradiation, and then they were split into two. One group got maintenance durvalumab therapy, and the other got placebo. Thank you. So you can see here about 400 patients got maintenance durvalumab after concurrent chemoradiation, and 200 odd patients only got placebo. And the median follow-up, you can say, quite good, of around 25 months. So here you can see there is a significant survival advantage, 65% versus 56%, significant progression-free survival difference with the addition of durvalumab post-chemoradiation. And if you see the side effects here, except for some hypothyroid and hyperthyroid side effects of durvalumab, other side effects were not too many with the continuation of durvalumab following chemoradiation. So therefore, even the NCCN is now recommending, and we have started using in our hospital for last about 1.5 years, definitive concurrent chemoradiation followed by durvalumab in stage 3 lung cancer. Coming on to the role of radiation in patients with oligometastasis, and frankly, as we were discussing Amish Vora's case about what should we do in oligomets? Should we paint them all like all metastasis, or they have to be different treated? So up to 5 metastasis. And this slide I was mentioning that even when you do chemotherapy, and if you add radiation in these patients, in the oligomets, there is an improvement in survival. Next slide will show you better. That you can see that the trials which were done without SBRT to oligomets were given only systemic therapy. They had poorer PFS and OS compared to trials with SBRT. So probably SBRT was contributing by way of immune stimulation, by way of immune response. So this is the same chart showing so many studies showing that when you add SBRT to the oligometastatic sites, there is an improved OS and improved PFS. Now coming to an important topic of this conference is what should we do as radiation in combination with TKIs. So the data about TKIs is there, but not too great. And we know that this is a good drug which shows good response rate in stage 3, stage 4 lung cancers in patients with mutations. However, 3 large adjuvant trials to give chemotherapy and then give adjuvant TKI were negative because they didn't use driver mutation. So very surprisingly, it was given to all, and therefore it didn't show the desired results. So this is a relatively recent trial which shows that you have patients who were resected for stage 2 to stage 3 lung cancer, and half of the population was given 2 years of adjuvant geftinib, and others were given chemotherapy as a post-op. So median PFS with geftinib was superior to 28.7 months compared to 16 months with chemotherapy, and it was statistically significant. And therefore, but there was no overall survival difference, but PFS difference was definitely there, which is also an important endpoint. So several ongoing trials are addressing whether newer generation TKIs, third generation TKIs can make something better even for survival. Now, talking about what I was touching upon in the initial slides, integration of radiation with immunotherapy. So as we all know that significant progress has been made in the immuno-oncology, and now we are discussing almost the whole day immuno-oncology. And we know these 2 people, scientists, got Nobel Prize last year, 2018, for these drugs. And these are the anti-PD1 and CTLA4, US FDA approval. These 4 drugs are now available, and they are in use, which we see in clinics. So, if we are talking of only standalone intervention with immunotherapy, and after spending so much of money and so many tests, the discouraging point is only a small proportion of patients get benefit, less than 20%. And that also is a short time benefit, it's not long time survival. So there is something happening with immunotherapy, and the promise which was shown is not actually being achieved. So therefore, is there any rationale of combining radiation with immunotherapy? And clinical evidence is accumulating for the synergistic effects of radiation with immunotherapy. So I was surprised when I saw a very latest publication in 2019 in the American Journal of Clinical Oncology, and these are the trials which have already been done. There are about 7-8 phase 1, phase 2 trials of combining radiation with immunotherapy, and you can see most of the time radiation and immunotherapy has been given concurrent, or at the first session of radiation the immunotherapy was given. So the best effect will be when we give it together. And these are the radiation doses. You can see 13, 3 fractions or 5 fractions high dose hypofractionated radiation. And one can see the median, this is the local control, these are the distant control, and you can see what they have compared with historical control, and they found superior local disease control and distant disease control, and even superior median overall survival. This bottom part is most of the retrospective series, and some of them have high number of patients, which I will show you next slide, of around 1200 patients in some of the retrospective series. This is one of the series reported in just about 1.5 years back. Radiation was combined with ipilimumab, 6th grade, 6th grade into 5 fractions. These are the response rates, and median overall survival in responders was much higher, 20 months, compared to non-responders, 3.5 months. This is another Pembro trial. Again, they are fairly recent, 2018. If you give Pembro with SBRT versus Pembro alone, Pembro with SBRT or in the form of radiation, response rates are much higher, statistically significant, 41%, and median PFS of 6.4% are much better than Pembro alone. So I think this is a food for thought for all of us, how we should be seeing immunotherapy. So this is the study I was trying to put. These are numbers are 1700 advanced non-small cell lung cancer. Again, these patients were given SBIT along with immunotherapy. Response rate, you can see 70% local where the SBIT was given, and at the distant sites about 40%. From 20 or less, it is now 40 and more. So response rates are higher, median PFS about 4 months, and then overall survival of around a year. So it shows a high rates of local control and provides a greater chance of obtaining distant responses because of the synergistic effect of radiation and immunotherapy. So over the past years, several trials, multiple trials have demonstrated that immunotherapy with immune checkpoint inhibitors, as 3-4 of those drugs are available, have combined radiation, and it is a promising approach. Current trials have demonstrated the potential synergistic effects, but still we don't have level 1 evidence of combining, and because most of the trials are small size, short follow-up, but it is a concept which is evolving very rapidly. Just to show you one case which we reported in our British Journal of Radiology, this was a young man who was referred to us, and he had inoperable chemorefractory retroperitoneal lymph node relapse from non-semiannuated germ cell tumor of the testis. This patient was diagnosed in 1995. He was diagnosed in 1995 with non-semiannuated germ cell tumor of the testis with paraortic nodes on presentation. So he had 4 or 6 cycles of chemotherapy followed by RPLND. He remained well for around 4 years. Then he had a relapse in the paraortic nodes. Then again he had chemotherapy with some partial response. Then he was given another 2-3 cycles of another kind of chemotherapy. Can I go back, please? Just the last line. So after these 3-4 lines of chemotherapy, and he had second RPLND also. And then he had this recurrence when he came to us after 2 surgeries and 3 lines of chemotherapy. That time we delivered, this was about 9 years back, when SBRT was new, we delivered about 45 gray in 6 fraction in 2010. And till today he is disease free. So the food of thought is that is it just the direct radiation effect? Why he got durable local remission? Why he didn't have metastasis? The answer, I'm not a scientist, but the answer, this is the PET scan pre-SBRT and post-SBRT, and now it's just on AFP, SCG follow-up for last, every 6 months he sent me on my WhatsApp the local levels, he lives in Shimla. So the answer is from here. Some systemic effects have been related to high-dose SBRT. Systemic effects. We are not talking of local effects. SBRT single doses of 2025 can substantially increase T-cell response and help to control tumor growth. This phrase studies I quoted in slide 1. So this could probably be an immune response to SBRT. That's what we have written in this paper. So to conclude, hypofractionated ablative SBRT or hypofractionated therapy is being pursued as a means to capture both. We are capturing both the direct cytotoxic effect and immune activating systemic effects. Optimal integration of radiotherapy and immunotherapy is yet to be achieved, whether it should be concurrent or it should be sequential, or sequential is on the first day or third day. It still needs to be sorted out. Future appears extremely promising to potentially convert radiotherapy into a highly effective systemic therapy in combination with immunotherapy. Thank you very much.
Thank you, sir, for a very thought-provoking lecture. Are there any questions for sir or the chairpersons from the audience? Yes, absolutely, sir. Can you please get a mic there?
Very nice presentation. You could understand the topic very well. Thank you. For us, it's a new topic. I just want to ask one thing. You have said that we have to give very high doses of radiotherapy to induce a tumorigenic response. What about conventional fractionation? Will it have? What I mean is that can we have immunotherapy integrated into our radical protocols later on?
The preclinical studies, they have shown that the dose per fraction and total dose have to be high because it all depends on how many cytokines are suddenly released. And that release will be higher.
They are giving radical course of 7 weeks. Can cumulative dose use a similar kind of responses?
Yeah, so whatever these preclinical studies, they have shown that there were poorer responses, and therefore all these studies have now come to some kind of a consensus that it is either SBRT like 3 doses or 5 to 8 doses. Because beyond that, immune response starts weakening.
No, Dr. Anil, as he's asking, don't you think that the basic question was the same like in locally advanced Pacific trial? And they said that once we give radiation, it increases immunogenicity and then you can continue with the...
So, other thing which Harit was also mentioning, he mentioned about post-surgery immunotherapy. And he said that earlier the better. Because again, post-surgery, a lot of cytokines are released when you are handling the tumor. Similarly, now concurrent chemoradiation, towards the end of chemoradiation, again we used to say that the most accelerated repopulation happens towards the end of treatment. So maybe that is the theory behind it, but the Pacific trial is very convincing. It has doubled up everything.
And so to answer that, there is a very recent data presented from some American hospitals. They have compared retrospective data. They have compared what you said, SRT and immunotherapy, chemotherapy and immunotherapy, EBRT and immunotherapy, and they found that with EBRT, the survival is actually less, and with SRT it is maximum.
Somehow something is missing.
No. See, basically, I mean, my radiation friends will know better. The concept is when you are giving low dose of radiation per fraction continuously, the toxicity on the lymphocytes is more. When you give a higher dose and give a gap, that toxicity is much less. So therefore, when you are talking about the immunogenic effects of radiotherapy, it makes sense that you give a higher dose and give a gap so that you lose less of lymphocytes. Because ultimately, if you lose that, then everything, the immunogenic thing is gone. And it has been shown, I think, in radiation studies that when you give a very low dose of radiation continuously, the lymphocytes die out much more. This does not happen in SBRT situations.
So other thing I can just add, that SBRT works also by stromal response. It is not direct cytotoxicity. So a lot of cytokines are released from stromal cells. So therefore, we want to exploit more and more the cytokines released from stromal cells, and for that, SBRT hypofractionated is better.
There's another point, when we treat radically, probably field size are bigger as compared to SBRT. So that means if you're treating bigger size, you're killing more lymphocytes. So maybe that is the cause?
No, so SBRT actually is indicated for, yes, we are all are using for upfront metastatic setting. Patient is on immunotherapy and there is, say, for example, some oligoprogression. And then we give SBRT and then subsequently again immunotherapy, then patient, they do better.
Yeah, so I think, after that. So I just finished with it. So I think we were just talking about whether the radiation should be given together. No, I think I will remember what you say first. I have forgotten.
It was a very nice talk actually. My point is actually when we are talking about immunogenic responses with radiation, so it's not that easy. It's a very complex phenomenon. When we are giving 2 gray of fraction, the tumor microenvironment behaves differently. When we are giving more than that, specifically more than 6 gray, then it behaves differently. And when we are giving more than 18 gray, then it's different. Yes. So usually the most immunogenic dose range is between 6 and 18 gray. So that is where there is a debate actually what kind of vaccination we should use when we are actually giving this kind of treatment for immunogenic.
So I now remember, now I forget once again. So there was a question whether we should treat the oligometastatic lesions without symptoms. Now all these trials, they gave SBRT, if there were 5 mets, they gave it to 2, not necessarily all 5, to induce an immune response, not necessarily to control the pain or prevent a fracture. That was given to induce the immune response along with immunotherapy. So in the talk in the morning we had this discussion that we will not give SBRT because patient has no symptom. But I think if you have to exploit it as an immune stimulator, then you have to give even without symptoms. Single fraction?
With 15 gray, good enough, you think, or you have to
If you see the table, I have not seen single fraction. So I don't know whether the single fraction till that time.
About 15 to 6 to 18 gray, single fraction is good enough.
You can give SRS we give, but SBRT also we give.
Induce immune response.
But
I use by 2 or 3 or 4 fractions.
Yeah, it looks like 2 to 3 days to about 10 days. Most of these studies which I showed in the table are 2 to 3 to about 10 days. Now, real thing inside what it is, we have to also study more. I think so.
I'd just like to make a comment. Like it started with metastatic disease, but I think the trials are on for radical treatment also. They're giving, 45 gray, 3 fractions, or So this is also for radical treatment, not just metastatic disease. Yeah, early stage, we already have a data of surgery versus SBRT. Not head and neck, we're talking about lung.
In Pacific, they have clearly mentioned that after concurrent CTRT, the maximum immunogenic response was between 12 to 14 days. So that means 12 to 14 days. That maximum immunogenic response.
Yeah. So the timing of durvalumab, so they have put from 1 day to 42 days, but ultimately